啊。Alright，我哋而家講緊呢一個 drug therapy assessment 嘅 table 係啦，咁如果miss 咗我個 beginning 嘅同學，可能麻煩你要問翻其他同學，因為唔好意思，我唔記得咗錄頭嗰20幾分鐘。OK，anyways，我哋而家喺呢一版啦，喺個course package 嗰度係講緊呢一個 drug therapy assessment 係點樣做。個 further plan 咧其實都差唔多，我諗你睇翻呢度啲 specific detail instruction 咧，你都大概明白。而我哋喺下個星期六嗰堂咧，我哋會 go through 一啲 examples。patient education 我可以講多句咧，就係其實呢一個我唔 expect 你一定要寫好多嘅，因為我知道可能有陣時有啲basic information storage 可能未必係好 relevant， 或者係depending on the issues，may not be relevant。你唔需要每一個都寫好多嘅，其實最主要係呢一度每一個 problem 你都真係應該要好 detail 咁樣諗過先至寫。So this really depends on the issue. If your patient is having, really an administration problem or is being started on a new drug, then you should say something here.OK， 但如果唔係，我個 patient 咧可能係一個 suboptimal dose。OK， 咁你個 patient education 可能好簡單嘅，淨係一個make sure you advise the patient that a particular dose has been increased, so on and so forth。所以呢度你唔一定要好 detail 好成本書咁抄晒出嚟，其實唔一定嘅。OK。好，咁我估咧，大家可能即係都可以用啲時間去消化下剩低呢啲其他嘅 issues， 裏面嗰啲問題係唔同嘅，會 gear towards 呢一個 problem 去提你，去 prompt 你去諗啲乜嘢 ，OK？ 咁即係話你做嗰陣時，你 submit at least 2個咁樣嘅 table 啦。OK， 有陣時可能有啲同學會有3個嘅，因為可能個 case 真係有好多 issues 啊咁樣。咁你同學有問過如果我 go beyond 1 page for problem 得唔得？可以，我明白好多時有好多formatting 嘅 issues， 你盡量 contain 你個 problem， 即係唔好乜鬼嘢都 copy 晒落去啦。OK， 盡量 contain， 咁 formatting 嗰度你盡量啦，但係即係主要你要有呢個 core 啦。你可以 delete 晒呢啲 questions 嘅，喺你真係俾你自己個assessment 嘅時候。咁下個禮拜六我會俾啲 example， 你望一望，好快即係 highlight 翻啲 thinking process 重點，咁你會有一個 better idea 啦。OK。好，有冇問題？關於呢一個 drug therapy assessment， 我 assume 你暫時冇先，因為我其實仲有 part 2， 我想 go through 一個 example 嘅。OK， 我會post 咗個 example， 或者我下個禮拜會俾個 hard copy 你，咁我哋會再講多少少。好，咁時間關係啦，我哋暫時呢度就講住咁多先。好，喺我開始講literature evaluation evidence-based medicine 之前咧，我就好想問一問大家，究竟因為大家 background 好唔同啊，我哋以前發現好多時大家識嘅嘢都好唔同，所以我想先有個 idea， 究竟你覺得你學嘅或者你 practice 過嘅，你對於 literature evaluation skills 咧嘅認識有幾多咧？或者你有幾 confident 咧 ？So， 我哋頭先講啦 ，you reply 你先入咗呢個 session 先10929 ，OK？ 咁麻煩同學答一答先。咁 A 就係最 confident 啦 ，E 就係最唔 confident 真係冇乜學過嘅，可能唔同嘅 program 可能 cover 得好少嘅。Alright， 好，等我俾多10秒，多啲同學答一答先。OK， 大部分同學似乎都係中間。好，明白。好，嗱，咁我都要講一講咧，其實我哋今日咧we're going to start on the actual lecture today for PHAL 5880, Principle of Evidence-Based Medicine, and also Literature Evaluation Part 1. Okay. My objective for today actually, we're going to go through the essential principles very quickly, and
Hopefully I can help you to assess the different sections of a study for comprehensiveness and quality. But to be honest with you, my session isn't going to be comprehensive. You know, if you say, hey, I really was given very little background on literature evaluation, then I'll need you to go back to the course packet. There's one appendix on literature evaluation skills, and I'll definitely need you to go through that after today to brush up on some background, because we're trying to focus on things that I would guess most of you don't know, okay, or most of you were confused about or don't understand those issues. Okay, so for more effective class time use, so we will highlight those. So if you get lost, confused, I need to back up a little bit. Do raise your concern during the lecture, and I minimize the control panel actually. So I'll need you to use the microphone to speak up or stop me if you have a question. And you can definitely ask the questions in Cantonese, that's fine, okay? We'll try to differentiate the different types of clinical trial designs. And in fact, the other very important objective is, I hope using this session, it will also help you with coming up with your own project proposal. Because, you know, if you know how to criticize others, hopefully you will at least know how to criticize yourself when you come up with your own proposal. Okay, so you should be able to apply the same principle with your own projects. So evaluate primary literature for the presence of bias, confounding factors, and also determine the effect on the validity, applicability, apply the concepts and techniques to critically appraise literature. So a whole bunch of suggested reading. I understand you don't have the time to go through it. This is really just for your background, or you know, if you have to go through them in the future. So now let's start with talking about evidence-based medicine first, before we talk about literature. So number one thing, you know, I think a lot of students think evidence-based medicine, it's about the use of guidelines. Okay, we use those overseas literature or local literature, and we apply it to local practice. Well, this is only part of the story. In fact, evidence-based medicine should include consideration of other aspects as well. Number one is the patient value. Okay, what does your patient want? What does your patient care the most? Is it side effects or efficacy? What is this patient's experience? Also, the clinical expertise. You know, literature can only tell you so much, okay? But there's a lot of things that it will depend on your experience. A lot of things will depend on other people's experience, okay? So all these need to be considered before treatment decision can be made, okay? And therefore, bottom line is, treatment decision should not be just based on available evidence. In other words, if you talk to a physician, if you only quote the guideline without consideration of those other factors, that's not going to be a successful intervention, okay? Other factors that needs to be considered, your patient's personal experience, your personal experience, some judgment will need to involve, and also the skills involved in getting the information from patient. You know, you need skills in getting the history, understanding the physical exam findings, and also the patient values and preferences. So why do we need evidence-based medicine? Obviously, the very clear purpose is to promote better practices. Okay, the combination of your knowledge, your experience, your skills, patient values, preferences, with the best available evidence should help to make the good clinical decision. And there are 5 steps in the evidence-based medicine model. Number 1, there should be a question, a clinical question that needs to be answered, formulate an answerable clinical question. And I think a lot of you have heard this system before, the PICO system, P-I-C-O. P stands for patient, I is the intervention, comparison of intervention, what are your options, and also what's the outcome that you are looking at, what you are aiming for. Okay, so there should be one question that needs to be answered first. And then you go ahead and find the evidence. And I know you guys are really good with finding evidence, looking through databases, literature, and so you should have no problem with that. And then now the third part is to appraise this evidence, you know, to understand the importance of all these pieces of information. Okay, what are the pros and cons of those findings or those suggestions? Did they consider everything? And then apply it okay, to your particular patient. Take into your patient's consideration, okay, take into account your patient's choice, allows a therapeutic alliance to be formed. Now, I know this is really hard to be done in Hong Kong, but realistically, I think some good practices does ensure the patient is in alliance. Good example would be in oncology. You know, if you need a patient to continue with chemotherapy, the patient needs to be part of the treatment, right? Same thing with psychiatry and some other disease state, actually empowering your patient, understand the patient's preference, the patient's own values would be really important when you apply those so-called best treatments. And obviously we do need to be practical and consider the cost, availability, etc. And then the last thing is to go back, okay, evaluate the performance of all those four steps. Whatever you suggested in the end, you know, you review to see if this actually worked. And this will build up in your own database. That's going to, with time, build up your expertise. All right, so to kind of refresh on this PICO system, okay, I give you one simple question that I think a lot of you have probably some knowledge about. So you have a patient who has sulfur allergy presenting with fever, and the physician prescribed celecoxib. So you wonder if this is appropriate. Now, first of all, we have to formulate this answerable question. There are four parts of this question. P stands for your problem or the major characteristic of your patient. So what is the P here? Can somebody either say it out loud or type it in the checkbox? What is your P? What is the I? What's the C and what's the O? All right, so your P, it's very good sulfur allergy, okay? Or the problem is the use of celecoxib with sulfur allergy. What about the I? What's the intervention right now? Well, obviously celecoxib, right? And then what's your comparison? Could be no drug or any non-sulfur containing fever-reducing agents. And then finally, the last thing is the outcome. Now, outcome, you can look at it from the safety angle and the efficacy angle. Outcome could be allergic reaction, which probably is the major concern right here. And then other times, you also need to think about efficacy, the fever-reducing capacity. For example, with celecoxib, is it better than the other agents? That would be one of your consideration as well. So your clinical questions would be comparing to the use of non-sulfur containing or fever-reducing agents, will celecoxib cause more allergic reactions? That's for the safety question. Now, for the efficacy question is whether it will give a higher fever-reducing capacity. Okay, so these are your clinical answerable questions. And I do hope that when you look at this, and I think you are, a lot of you are probably thinking about other things, not just those two questions. Can somebody tell me, you know, any other thing that came to your mind when you see this issue or see this question? Anything else came to your mind? So let's say if you, okay, reason of the fever. Good. All right. What else? You know, you see a patient in the profile, it says sulfur allergies, and then prescribed with celecoxib. All right, good. Has the patient used Celebrex before? What else? What else? 大家覺得 sulfur 同 sulfonamide 係咪一樣啊？ Sulfur allergy 同 sulfonamide allergy 係咪一樣啊？ Okay, good. 有同學就話啦 whether the sulfur allergy is more related to sulfonamide antibiotic or a pure sulfur group. Okay, 咁我諗 at least 同學大家大部分都知啦，其實 sulfur allergy technically it's different from sulfonamide allergy. But I can tell you a lot of times, even though if the patient has sulfonamide allergy, the documentation would say the patient has sulfur allergy. My mom was actually a patient with sulfonamide allergy, but for years, her record says sulfur allergy. Okay, so when you see sulfur allergy, you wouldn't assume it's sulfonamide. And although 99% of times it's probably sulfonamide allergy, but there are groups of patients who are really, you know, allergic to sulfites or those preservatives or really sulfur. Okay, so either way it's possible, but I can, you know, we all know that the terminology is often confused. All right, so now let's say if it's a real case. Okay, I need to know what you would do. Are you going to intervene or are you not going to intervene when a patient is having this issue? OK， 有同學揀 A、B、C、D 都有，多同學揀 B， 多同學揀 D。B 咧就係 yes if the patient had taken Celebrex before, and then D is no, should use other NSAIDs over Celebrex. OK， 咁其實呢個真係一個 real case 嚟嘅。Well, obviously, you know, a lot of us are aware of this. You know, the package insert, it's still saying that it's contraindicated. And then any other things that you would consider? 仲有冇其他同學有其他考慮㗎 ？Intervene or not？ 除咗呢幾樣嘢之外。好啦，咁我哋就 let's try to do it together. So if we were to use the evidence-based medicine model to critically think about this very simple question, what is the current recommendation? So you find the evidence is in the package insert, and sometimes you might have to go to the primary literature. And then you need to think about what are the risks versus benefit of using and not using Celebrex in general. Okay, and also what is the risk versus benefit of using and not using Celebrex in this particular patients, considering the patient's own risk factors. All right, so I actually went ahead and then did the information search many years ago. So went to the package insert, some primary literature, also went through the scientific basis. But now what I want to share with you actually is this case. So 大家一齊睇下啦，幾 interesting 嘅一個 case 嚟嘅。咁呢個 patient 好叻啦，自己知道原來自己係 sulfonamide allergy 啊。大家覺得點啊？好慘，純屬不幸係嘛？Okay, so after seeing this case, obviously we want to learn from the experience. Okay, so why don't we take a step back instead of, going directly to say yes or no? We want to go through the necessary step to dissect this case. First of all, understand its scientific basis. We know sulfonamide, it has this particular chemical structure, and there are two major types of sulfonamide-containing medications that are commonly used: the antibiotics and the non-antibiotics, which include furosemide, diuretics, and also celecoxib or Celebrex. But there are some major structural, so scientific differences. Sulfonamide antibiotics usually contains this aromatic amine group with this particular structure. It's it's an allergen that leads to or linked to the development of IgE-mediated reactions and hypersensitivity reactions. This is with the antibiotics. But those non-antibiotics like Celebrex do not contain the same structure. So severe allergic reactions are actually not expected to occur as frequently as the antibiotics. Yet, you notice it's still in the package insert as a contraindication because, in fact, oftentimes the sulfonamide allergy can cause T-cell mediated reactions. Okay, so still some cross-reactivities that are due to those T-cell mediated reactions. So this part is actually common to all sulfonamide containing compounds, okay, which is this structure here. So it's still in the contraindication, okay, although we know they are not structurally the same, okay, that are two different pathways. So that's the scientific part of it. What about literature? So went back, it's not easy to find large-scale studies on allergic reactions. Okay, you might see data, but then a lot of times they are not really studies. So I actually found this pretty big one that was published in the New England Journal of Medicine. It's a large retrospective cohort study that determined the risk of allergic reactions to sulfonamide non-antibiotics. Okay, so what the study did was they included patients who have documented history of sulfonamide antibiotic allergy. So these are the known antibiotic allergic patients, and their controls are those who do not have antibiotic allergy, but they might have other allergies, okay? Both groups then went on to subsequently receive drugs like Celebrex, or I should say the non-antibiotics, okay? So what happened is the antibiotic allergic group, 10% of them actually develop an allergic reaction. Okay, now the non-antibiotic allergy group, that's a really big group, and actually it turns out to be only 1.6% of them having the allergic reaction. So if you just look at this number, if you just read the abstract, you're going to think that, wow, so there is a cross sensitivity, it's going to be like 1 in 10, right? But the other thing that is extremely interesting found in the study is comparing to the patients who have a history of sulfonamide antibiotic hypersensitivity, those patients who have a history of penicillin hypersensitivity actually almost had a higher risk of developing allergic reaction to the sulfonamide non-antibiotics. In other words, those who only had penicillin allergy actually just also develop allergic reaction to those non-antibiotic of sulfonamides. Does it mean there is a cross sensitivity with penicillin and sulfonamide too? No, right? Actually, what's concluded is the allergy to sulfonamide antibiotic, it's a risk factor for subsequent allergic reactions to sulfonamide non-antibiotic. The risk is very small though. The actual cross reactivity, it's very small. Rather, it's due to the fact that there is a predisposition to allergic reaction. Okay, in other words, a lot of times these patients have a certain drug allergy. They might be also allergic to many other things, which totally is applicable to our case, who also has penicillin allergy, remember, right? So everybody get it? 即係話其實唔係因為個 cross reactivity 或者 cross sensitivity，而係當一個 patient 有咁多藥佢都敏感嘅時候咧，其實係 imply 咗佢本身就係對好多嘢都好容易敏感嘅。OK， 去到呢個位咧，咁我哋又再諗咯喎，好似呢個 study 可以 apply 落去呢個 patient 嗰度係咪啊？大家明唔明啊 ？so far 都 OK 嘅嗬。但係咧有一樣嘢我未講嘅，就係其實咧呢個 study 係2003年嗰陣時做，即係好多好多年前做㗎啦。個重點係咧，因為佢係 retrospective cohort study， they have to go back to dig out charts, dig out data. Okay, so the actual data is even before 2003. That was in the 1990s, late 1990s. That was actually the time that Celebrex was not approved. In other words, this study actually did not include Celebrex, or if there is, there's only very few cases. Okay, most of the patients were on like frusemide or other sulfonamide non-antibiotics. Okay, so again, that's another thing that you need to consider. If you were to quote this study, you better know that this actually did not include Celebrex. Okay, but can you apply the same principle to Celebrex? You probably can, right? Given they are the same group of drugs. So overall, the existing data does not support a high likelihood for cross-sensitivity between sulfonamide antibiotics and Celebrex. Okay, in other words, if you look at this case, was the claim substantiable? 話個醫生錯，咁其實係咪真係個醫生錯啊？或者我哋藥房同事照出，係咪我哋同事錯啊？照出呢啲藥？ Well, the actual decision actually should be based on this. In the current case, given the strong history of allergic reactions to various agents, the more appropriate options are actually available, right? You really just, let's say if you're really using it just for cold and flu, right? For could be for arthritis, but there are other drugs also. Okay, so for the antipyretic, anti-inflammatory effects, this patient required for the flu-like symptoms, there are actually more appropriate or safer options that should have been used in this patient instead of the Celebrex. All right, so I hope that was an example that showed you, sometimes it's not that straightforward. It's not just what the contraindication says. It's also not just what people's experience are. It's not just either one. You do have to go through the information and also think about whether this is applicable to my patient case. So now let's move on to talk about the literature. Okay, study design and its level of evidence. Next couple slides should be just things that you know already. Okay, it should be things that you have already learned. You know about what are the strongest evidence and what are the weakest. As you know, the experimental interventional studies, in particular randomized controlled trials, are usually the gold standard or most trustworthy if it's well done. Okay, and the other thing that I do want to bring up here that you might not have heard a lot about is the quasi-experimental design, which is one type of non-randomized control trial. And in fact, the reason why I want to bring it up is because oftentimes our students, when you do projects, you actually could be carrying out a quasi-experimental design. You have a control, but you didn't randomize or you couldn't randomize. Okay, so the existence of those quasi-experimental trial design oftentimes is when you have some cost concerns or some ethical concerns. Therefore, you do not randomize or you cannot randomize. Okay, now they are still considered interventional studies, but it's quasi-experimental. It's not like a real one. And we'll come back to this because I think this will be something that you should be looking at for your own project as well. And then we have observational studies. The better ones or the best one among this bunch would be your cohort. And case control and cohort are still considered analytical kind of observational study. Cross-sectional, a lot of times it's more like descriptive. Okay, you're describing the disease prevalence. Meta-analysis could be good evidence if it's well done, but it's very hard to have a very well done meta-analysis. It's very complicated. Statistically, it requires a lot of knowledge. And then we have others designs, as you know, guidelines are actually not considered really evidence. Guidelines are just sort of similar to the expert opinions. These are very low evidence value. And then the next couple of slides, I'm just giving you this information for completeness about, some brief description of RCT's cohorts, case control, so on and so forth. Now, this is really just for refreshment. I'm not going to go over it. And I think Wilson will talk a little bit about RCT and cohort later on in his session. Instead, what I want to say more, it's about the quasi-experimental study. So quasi-experimental study is often used to evaluate the benefits of specific interventions instead of drug effects. Now, RCTs are often used to compare drug efficacies. Okay, observational studies are often used to look at exposure and the disease outcome, more like epidemiological studies. Okay, they look at the exposure to cigarette smoking and the development of, say, stomach cancer, okay, lung cancer. Okay, those are epidemiological type of study. And in the past, when we didn't know about the quasi-experimental study, sometimes we used the cohort study design for our pharmacist intervention study. Okay, sometimes we call them retrospective or prospective cohorts. And make it sound observational so that hopefully the ethics committee will approve it. Okay, so that's another thing that was done in the past. But in fact, you have to understand the quasi because quasi is a better description of those study design. So it's applicable in situations where it's not feasible or ethical to conduct RCT. May be applicable in many pharmacist service intervention studies. And one example here is the IPMOE system. Let's say if it's implemented and the study's aim is to study the impact of intervention on reducing medication-related adverse events or costs before and after. the intervention. Okay, so there's now with quasi, you could have a control group, or you could have no control group. So there are many different types of quasi-experimental studies, in fact, okay? Without a control group, this is your before and after or pre-post comparison. 淨係睇自己喺 pharmacist intervention 之前個 baseline versus 之後 okay, for example. And then there could be the use of control groups, but there's no pretest. 即係話大家有兩個 arm 嘅 okay, not randomized. There's no pretest, maybe there's no baseline, okay, and you only compare the final outcome after the intervention in that intervention group, and after the same time period in the control group. And there could be the use of controls with both the pretest. Okay, this is also considered a quasi-experimental study. And finally, we have also other types, which is the best type so far for quasi-experimental study is actually the interrupted time series. Basically, multiple measurements were done before the intervention. Let's say 2 or 3 or 3 or 4 measurements of hemoglobin A1C are collected before the pharmacist intervene. And then 6 months later, after the intervention has been done, you also collect, at the outcome time point and also at the follow-up time point after the intervention has been withdrawn. Okay, after intervention has been withdrawn, you also monitor the patient's responses. Now, depending on your study hypothesis or what you are aiming for, looking at, you might expect the A1C to get worse or the A1C to remain the same as if the patient was receiving intervention. Okay, so these are called the interrupted time series quasi-experimental studies. Now, what I wanted to, bring up to you is that there is a pretty good article. It's very easy to read article on the quasi-experimental studies, and they give examples of, or they reference examples of those pharmacist interventional study that adopted the quasi-experimental design. I think that's very handy if you try to, look more into the study design, think about what you can use yourself. So I would suggest you to go to this reference, very easy to read, and it's not very in-depth, but good overview, good idea. And the quasi-experimental study, if it's well done, if you have say the time interrupted series kind of design, that's great. That's actually the best level. Okay, if you don't have a control group, if you don't have any pretest, you're just doing like a pre-post comparison, these two are considered the weakest design. These two are the weakest design. Okay, so ideally you would hope that you can collect a lot of data before and after if you have to go through this quasi-experimental study, and that will need time. That will also need resources. Therefore, you have to do early, plan it well. And the quasi-experimental study, because it's not randomized, it's also subjected to many internal validity issues that apply to other non-randomized controlled trials. And these are just to name a few of them. The temporal precedence is sometimes ambiguous. Lack of clarity on whether the interventions occur before the outcome. Okay, sometimes, you don't know if the outcome is already there, if, you just didn't collect it, for example. Or sometimes there could be effects occurring concurrently with the intervention that cause the observed effect, making your outcome subjected to challenge. It may not be due to the pharmacist's education that the patient's A1C improved. It could be due to maybe the physician change, the nurses change, so on and so forth. And then selection bias, we're going to talk about this later on when we talk about biases and confounding factors. Basically, this is a systemic differences over conditions in respondent characteristics that could also cause the observed effects. Meaning that the patients that were recruited in the study, they have some baseline uniqueness that actually affected the results. Those respondent characteristics actually cause the effect instead of the intervention. Attrition is the loss of respondents that can cause some artificial effect if that loss is correlated with the intervention. And then testing is the exposure to a test that affects the score, because these patients were tested over time very vigilantly. The patients might be more cautious. The patient might be taking better care of themselves because of the testing, not so much because of the intervention. And then, there are other things that I guess I'll leave them to you to read about, these potential biases and confounding factors. So overall, to sum up, why do we want to learn about literature evaluation? And I hope you do find it fun so far. There's not a lot of memorization you have to do. It's more like understanding and thinking. In reality, you probably don't have the time to critically evaluate literature. Okay, I know you don't, but then I do think this topic is important because it instills this critical thinking process. You can apply this mindset thinking process into other things as well. All right, so now you guys need a break. Should we take a break? Yes, no? All right, I'll decide for you. Why don't we take a very short 5-minute break, and then we'll come back to talk about the detail of a piece of literature. So we'll come back at 3:42. OK，翻嚟啦，大家喺度嘛？OK，有冇問題啊？冇問題。Okay, good. So why don't we just go on? All right, so there's been a lot of guidelines on how studies should be reported, and the consort statement, it's one very famous guidance on the essential aspects of good reporting of randomized controlled trials. So it's the consolidation of reporting trials guideline. So you can take a look at it, but I think the next two slides summarizes the essential aspects, and I think I did give it to you maybe in one of those packages. But either way, it's just outlining what needs to be included in the reporting of a randomized control trial and the clarity, they should pay attention to. So we will discuss some of those aspects. We're not going to have time to go through every single thing that was stated in the consort statement. All right, so next thing that before we really go into the journal critique, we should talk about the differences between bias and confounding factors. Now, bias is actually different from confounding factors. Bias is introduced by the improper design of a study, okay? Now, bias sometimes can be prevented if the study was carefully designed, but sometimes it cannot. Sometimes you just cannot avoid it because, this is just how you have to do it. And but you have to at least be aware of it when you get challenged, or you need to do certain things to minimize the impact of those biases. So it's the systematic error that affects your outcomes. So there are other things rather than your intervention actually affected the outcome. There are many different types of bias, but in general, you can categorize them into a few big categories: selection bias, measurement bias, and intervention bias. Selection bias, it's about the subjects that are recruited, okay? There are many, many different types within the selection bias, and you're going to run into different terminologies. And I would suggest, maybe you can look into it. You can just do a quick Google search. You're going to see a lot of different types of bias, okay? But essentially, selection bias example could be, so let's say if you were to do a survey, some people respond to you, some people don't, okay? And if you think about it, obviously you have to count on those who responded to do your analysis. But the thing is, what about the non-responders? What do they think? Is it because they think your intervention is really bad and they don't respond? Okay, so you have to be aware of the non-respondent bias. And then volunteer, it's also another issue. Now, imagine if you have a project that you ask the physicians to refer patients to you, versus if you have a study that you put up a poster in the waiting hall and you try to recruit volunteers who come to you and say, hey, I want to be intervened. Are these two groups of patients different? If you think about it, those who get referred versus those who volunteer. Obviously, those who volunteer could be more health conscious. Oops. 我又唔記得咗開返個 recording。明明我冇刪，好彩嚇死我，好驚啊。Okay, I'm sorry, back to this. So obviously we were saying that those who volunteer are more health conscious, and they could be very different from the general population that you expect. Okay, so that's one thing to pay attention to, the selection bias, how people are recruited, or what kind of subjects are being recruited. Are there certain problems? Okay, for example, those drop out, again, are also things that you want to consider. If you have a lot of patients who dropped out from your study, what happened? Why are they dropping out? Is it because your intervention didn't work and therefore they don't come back, or is just simply because they are they're just very busy and they don't have time to come back? Okay. And then the other thing, it's about measurement bias. Measurement bias comes from how data is collected. It could be observer bias, recall bias, instrumental detection attention. So attention bias is talking about, how in a study you are going to check your hemoglobin A1C every 3 months, for example, and you have to come back to get your blood drawn, you come back to talk to the pharmacist, and then you get a lot of attention. Okay, all these attention itself can cause a measurement bias instead of your actual intervention, just sort of similar to the project that I explained to you on the first day of class. Okay, and then instrument detection bias, that is talking about maybe, for example, blood pressure measurement. Okay, blood pressure studies could be very tricky to do because you have to make sure that you use appropriate method to measure blood pressure, because obviously if you measure blood pressure right now versus 2 seconds later, the number can come back different, right? There are a lot of natural variations. So are you doing the best you could to minimize those measurement bias? Okay, is the instrument being used appropriately calibrated? Is it trustworthy? Recall bias is referring to, let's say, in a retrospective study, you will often, especially say case control study, you're going to interview your case patients to ask them about the exposure, right? You ask those patients who have breast cancer, did you use oral contraceptives 30 years ago? Okay, now obviously case patients are going to be able to recall those medications or potential risks a lot better than the patients who do not have breast cancer. Okay, your case is going to be a lot more aware of any exposure than your control patients. Intervention bias is talking about the proficiency. Okay, the one who does the intervention, that oftentimes you have a replacement, you're going to have substitute or people who help you out, right? Are these people all adequately trained, or are people being consistent? Okay, and how long is the intervention? Was it adequate? Is there any different duration of intervention that's being adopted by different people, causing a different effects? So those are biases. I guess if you were to kind of remember biases, how it differs from confounders, is bias in a way can be prevented, okay, with a careful design. Confounding factors, on the other hand, though, oftentimes they naturally exist in a condition that's being studied, and they may affect the outcome the same way as the bias, but these are almost your patient factors, your patient risk factors that you are bound to have it if you recruit patients. Depends on how the study is designed. If it's randomized control trial, you hope those confounding factors will be equally distributed between the two groups. Okay, because you randomize patients into intervention, you randomize into control. There could be sicker patients in the intervention, at this moment, but then the next moment you're going to have the as sick patient in the control group. So randomization helps you to equally distribute or evenly distribute your confounding factors. So one example could be, patients who have uncontrolled diabetes and hypertension in a study, okay, that is evaluating the progression of the renal dysfunction. You're trying to look at the use of ACEI in preventing the progression of renal dysfunction, but your patient's having uncontrolled diabetes and hypertension in, say, the control group. Now, it could be due to the fact that the uncontrolled diabetes and hypertension make these patients worse instead of an uniqueness with your ACEI. And therefore, whenever you see those studies, usually they ensure both groups got the same hypertension control. Okay, they use other drugs to achieve the same level of control of hypertension to minimize this confounding factors. So the confounding factors can be controlled by the use of exclusion criteria, some restricted randomization, stratification, matching. We'll talk about these later on. These are skills used in randomized control trials to minimize confounding factors. And they can also be adjusted for in statistical analysis as well. Now, I do want to make sure that you understand both bias and confounding factors can happen in randomized control trial and also those observational studies. Okay, but more of a problem in observational studies, because RCT, obviously, you can control your confounders using many different well-structured way. You can just build it in. But observational studies is, you're very passive. You're just collecting data that has already happened. So some example of confounding effect, straightforward, simple things that you understand first. Try to study the relationship between coffee drinking and also pancreatic cancer. Same time though, smoking is a known risk factor for pancreatic cancer, but it's also associated with coffee drinking. In other words, people who drink coffee say they might be more likely to smoke. Okay, and smoking is the risk factor that is proven to cause pancreatic cancer. And if you want to study the relationship between coffee and pancreatic cancer, say you found an association, people who drink coffee are more likely to have pancreatic cancer. You have to be careful, because is it really the coffee drinking that causes the pancreatic cancer, or is it the smoking that these coffee drinkers often do and should lead to the pancreatic cancer? If you overlook that, obviously you're going to make a wrong conclusion to say coffee drinking caused that. Now, another example, okay, of confounding factor. There was a study done by one of our students years ago when they conduct this dyslipidemia education. Okay, the aim obviously is to use pharmacist intervention to reduce LDL. Okay, so I kind of simplify it in this diagram so that you can see. So the intervention group say that baseline LDL was 6, and the control group say that baseline LDL was 5.8. I think it was a randomized control trial too. So the pharmacist gave intervention in the intervention group, okay, and unfortunately, months later, the LDL didn't come out better than before the intervention. Now for the control group, they also didn't get better, okay, so both didn't get better. So the pharmacists or the students tried to explain, it was the seasonal holiday effects that affected the dietary intake and therefore the patient's LDL control. Because of these concurrent happenings, our intervention wasn't able to exert the fullest effect, or, in a way almost implying that if there wasn't pharmacists, with all these seasonal effects, these patients in the intervention group could have even worse LDL control than 6.2. So what do you think about that? Is that a sound explanation to you? Do you believe that explanation, in other words? So do you believe that was because of the seasonal effect？ 因為過年嗰段時間咁啱，又真係好多時候同學做呢啲 project 就係聖誕。Okay, so some of us believe, okay, that's true. Christmas, Chinese New Year, maybe that's when people eat a lot. That's true. Anybody else? Other thoughts? Okay, well taken. Any other thoughts? 其他同學呢？即係大家都覺得，如果假設你做一個咁樣嘅 project，end up，哎呀 ，unfortunately you didn't do better。
you would explain with the same reason.呢個你一定要答㗎。Okay, methods of intervention not effective. 係啦，點解你會覺得個 intervention 可能唔 effective 咧？ Based on what you think it wasn't effective. How many patients were taking drugs for dyslipidemia in both groups? Okay. 有冇其他 idea？ 有冇其他 thoughts 啊？其他同學咧？ Certainly, drugs can affect the dyslipidemia control. 呢個係嘅。但我一陣間會解釋呢一個係點樣去 understand。Patients tend to do less exercise during holidays. OK， 好啊。嗱，其實呢個 project 嗰個 issue 咧就係咩咧？呢一個咧其實係一個 randomized control trial 嚟嘅，佢有 control。咁有同學就講啦，OK， 你都要睇下個 control group 嘅喎，係咪啊？My question would be, or some of you probably are questioning the same, is, all right, if seasonal is an effect, then seasonal is also an effect to the control group too, right? 係咪啊？大家都 go through Christmas 同埋 Chinese New Year 啊，係咪啊？ Now, that's why we need to have randomized control trial, okay? Because your control would show you the effect of all these seasonal things. In this particular case, your intervention group had a slightly worsened LDL level, like by 0.2, okay, and then control by 0.1. The absolute number, the absolute numerical difference actually doesn't matter. The point is, you know, if you're talking about seasonal effects, then both groups are subjected to it, okay? Then you would at least expect your if you compare the two in terms of the change, okay, the change in the LDL, statistically evaluate the change, you would see hopefully the intervention group will still do better than your control. The control is controlling for all these seasonal effects, all these concurrent happening if you have a randomized control. Okay? Get it? So do make sure you understand what you are saying. Does it make sense? You know, can you really explain this by this particular excuse? Okay? In this case, it's not believable because you have a randomized control group that is experiencing the same seasonal effects. Now, how would it make sense if you really didn't have a control group? 如果你淨係得 intervention group 嘅，咁 before and after， 哎呀差咗，咁你可以話seasonal 可以係一個 effect, okay? But what does it tell you? That tells you your study design wasn't good enough. Because remember, when you don't have a parallel control group, this will always make your intervention or your outcome subject to a lot of other factors. Okay? So the design is not that great if you have an interventional study that doesn't have a concurrent control, because people can easily challenge your benefit by saying it's, you know, it could be due to the doctor, it could be due to the season. 即係話，其實反過嚟講，如果你淨係得一個 arm， 淨係得 intervention arm， 就算你好咗，人哋都可以話，可能係一個 seasonal effect 喎，佢之前聖誕新年食肥咗，而家去到你嗰度佢自然好咗都得㗎。So I think you all understand this by now.
And then the next slide is about some strategies for reducing confounding factors in non-randomized controlled trials. Okay, now it's really not that easy. Okay, it takes a whole design to address those confounding factors. But the one that I do want to point out to you is the propensity score. Maybe some restriction and matching that we'll talk about later on. Okay, the concept can be used when you do your own project. Propensity score, it's the conditional probability of exposure to an intervention given a set of risk factors that may influence the likelihood of exposure. Okay, propensity score may be used for matching, stratification, and regression. So what does it mean? Propensity score, when it's used in those non-randomized or observational trials, propensity score detects or deduce how likely is this person going to be given a treatment based on the risk factors that he has. Okay, so how likely will this patient be given a treatment based on simply the risk factors that this person has? Why does it matter? Because the risk factor can be what causes the outcome instead of the actual intervention. Okay, I'll give you an example later on. We'll come back to this, just a snapshot for you to see there are different strategies used for reducing confounding factors. All right, so now getting to the meat, the actual piece of literature. And so we'll highlight on all these, the title, your abstract, the introduction, methodology, results, discussion, and conclusion. For today, I think I can finish up to somewhere in the results, and I'll save the rest for our next session. So first of all, title. A lot of students struggle when writing their own title. Okay, a lot of students find it really difficult to do and end up having something that's not eye-catching enough, something that's too long, that doesn't have the essential. So title, again, is supposed to be succinct, contains the essential that adequately inform the content, should be concise, definite, but neutral. Okay, should be neutral, doesn't predict a benefit. Also, eye-catching, catch people to read your report than others. So the example could be the risk of pneumonia and all-cause mortality associated with the prescription of antipsychotics in elderly patients with dementia in Hong Kong, a one-year hospital-based retrospective cohort study. This is actually a study that my students did years ago, okay? So when you look at it, obviously this is way too long, right? So I have them shorten it to something like that. Antipsychotic use on the risk of pneumonia and death in demented elderly, prelim findings of a retrospective cohort study. It's still kind of long, but at least better, okay? So it's actually very subjective. What is considered essential? What is considered not essential? You will have to make this decision, okay? You will have to decide what can be gone. But one thing that is very sure is if your title is too long, your audience is just going to be confused and don't know what you want. Next is abstracts. There are many standard abstract formats, okay? So in your graduation projects packet, I actually gave you a guide to writing an abstract. It's very important. You must read it before you do your own final report writing, because what realistically happen is some students have no idea about how to write a good abstracts. And when they get so busy with writing up the actual body, they always save the abstract as the last step. They use the least amount of time and make do a really lousy job with the abstract. But let me tell you what, just like you guys, the abstract, it's the only thing people read. If your abstract is crappy, people are not going to read your report and people are not going to take your report seriously. So abstract definitely is worth investing. So these are usually the standard format requirements of an abstract. So Abstract efficient summary of the study that facilitates one's search for the pertinent articles. It must be consistent with the main body. Okay, this is also important because if you make a mistake, people are going to think that, wow, this is not trustworthy, because you can screw up numbers, you can be missing a decimal as well. So not very carefully done, and that discredit your work. Abstract should not be a substitute for full text when you are really using that article for important intervention or for interventions. That in those situations you must read the full report. Abstract is for screening. Okay, why is that? Because oftentimes there are misleading information in the abstract. There are often inconsistencies with the published article. There are inconsistencies between the abstract and the body, and there are omitted data. So just a couple fun examples, really old article, but I still like to use it because they are so classic. Okay, so in this particular abstract, it says the survival was longer in patients who are operated using this particular strategy. Okay, so if you just look at the abstract, you believe this strategy or this procedure works, right? It helps. But when you actually read the body, it says the difference was not statistically significant. Okay, so a lot of misleading information can be found. Another one here, it's in the abstract, it says the survival estimate was 65%, 48%. But in the body, it says something different. The numbers were off. Okay, so again, careless mistake, discount your report. So from a bigger scheme, what about overall instead of those individual examples? In many years ago, in 2004, there were studies that sampled abstracts of original research over 1 year period, and they found that 25% of those abstracts contain omissions, and 33% of them contain inaccurate information or omission. 60% were deficient, were not good enough. What about something more recent? In 2017, this group of investigators, they actually looked at the abstracts for the ASCO meeting. ASCO, it's a big oncology meeting that, they announce the best, the cutting edge oncology research results. But unfortunately, what they found is those abstracts, 8 years apart, there are still problems with the abstracts in 2015. 21% of the abstracts actually didn't report the phase of the trial. There were also a lot of clarity needed on whether even the primary endpoint was met in many of these abstracts. So again, the story is a lot of caveats. Be very careful with your own, and be careful if you only read abstract and you making an important suggestion, or you are going to talk to people as if you really know the stuff. You have to read the full report. So next is introduction. This is my favorite because MCP students tend to give us really basic introduction when it comes to your own proposals. Okay, example could be a diabetes intervention study. I've gotten so many proposals that the background start with the pathophysiology of diabetes, and what are the most common complications from diabetes. So basic, you have to remember people who read your proposal are either at the same level or above. Okay, you have to make sure that your introduction is very well written, that sells your projects. Main purpose of introduction, create interest and for readers to understand why you are doing this project. Okay, so the essential elements in it is to provide valid reasons supporting the need for this study, indicate the potential benefit. Now here you can indicate your benefit, in your title you cannot. Okay, and you include the most pertinent and updated literature to orient your readers. Okay, and so a diabetes intervention study, I would hope that at least you would include the new or more updated pharmacist diabetes intervention saying that it works or saying that it doesn't because people didn't do certain things. Okay, you need to do more in-depth literature search and be able to give a very valid rationale why you're doing this particular study. And I totally understand realistically, you're doing a particular study because maybe there's no local data, or maybe because your institution just needs it or just wants to do it. That's fine, but you still have to sell people your angle. You need to find an angle, and trust me, if you put some thoughts in it, you will always be able to find something. All right, your hypothesis is the research question. Is there always a hypothesis? We say there's always a working hypothesis, meaning there should always be something that you are trying to understand. If everything is so well understood, you don't need a project. Okay, so there's always something that there's still something that needs to be clarified. There's still something that needs to be known. Okay, then you do a project. So the research question is a key question that's being tested, and most of you probably know about the null hypothesis. Okay, and in general, statistics is trying to reject or help you to reject the no difference statement so that you can be in favor of the alternative hypothesis, which is there is a difference statement. Okay, we cannot prove there is a difference, but we can prove that no difference is wrong. All right, next thing that we're going to talk about is the objective and hypothesis. Okay, because I'm not going to cover everything, so I try to include some assessment questions for you so that at least you have an idea about what other things need to be considered. So objective needs to be smart. This will go through because objective is very important. You have to know how to write a good objective and evaluate other people's objective. It's the hypothesis stated. We have just mentioned the hypothesis. Now, I actually think that it would be nice that you have a hypothesis, especially if your study is doing some comparison. Okay, if you're purely descriptive, sometimes you don't have to have a hypothesis because you can't really prove anything. You're just describing, the interventions that you did in your service. Okay, you might not have a hypothesis in those situations, but you should still try to think of, do I have a working hypothesis? Do I have really something that I am trying to see, or I'm trying to state that other people don't know yet? Okay, was the study designed properly to achieve those objectives and test the hypothesis? That's the coherence that we should be looking for. Is the whole thing designed to achieve the objective? And if you don't know what you're looking for, you'll never understand what you find. All right, hypothesis. In the case of a superiority trials, which I guess most of us will be doing or will be evaluating, this is just background. No hypothesis means no difference. One example could be there's no difference in the proportion of enalapril-treated survivors with the proportion of hydralazine nitrate-treated survivors. And the alternative hypothesis is there is a difference, and usually what the study or the superiority studies try to do is to reject this null hypothesis to make alternative hypothesis stand. All right, so now objective. You will learn more about writing a good objective in Wilson's session, but at least I want you to have some idea, some background, what you need to have. SMART stands for specific, measurable, achievable, relevant, and time-bound with a time, okay? So the very important features of an objective is you have to have what is being compared. Are you comparing your intervention with usual care, for example? What is going to be measured? Are you measuring blood pressure, A1C, or a certain psychiatric scale, or depression severity? Okay, you don't necessarily always have this exact scale or the exact parameter in it, but at least you give people an idea. You are measuring blood glucose control. Okay, so be more specific about what you're measuring so people understand it's measurable or not. So one example could be, obviously the subject's going to be evaluated, right? So an example, this 6-month study is designed to compare drug A with drug B in the treatment of type 2 diabetes in adults by measuring A1C and fasting glucose.
Okay, that's a really or more or less elaborated version of objective. And the wordings that you're going to use oftentimes is to evaluate, to compare, to investigate, to describe. I think compare, it's a good word if you're doing something quantitative. You know, you compare the glucose control, you compare a certain disease control, okay? To describe, it's oftentimes very descriptive, okay? Depends on what you're doing. You know, you could be trying to describe certain thing if you are doing a descriptive projects. And then to evaluate, you know, it's also very frequently used. It depends on what comes next. You know, are you being clear enough about what you're evaluating? When you evaluate a study, you have to go back to the objective when you evaluate it. Why? Because you want to make sure that this project is not deviating from the original objective. Okay, the objective is to measure the glucose control, for example, or the disease control. But then if you find that, oh, I'm reading a lot about the side effects, how well tolerated this is, you know, how much better this is based on less drug interaction, then there's a problem. Okay, that means it may be deviating from your objective. So be careful with objective that sounds like it was conceived after the data collection was completed. So just to show you some examples of objectives and hypotheses. So in this particular study, you're looking at the comparison between the valsartan and amlodipine, okay, ARB and a calcium channel blocker, to see how the hypertension is being controlled. So this study, if you look at this first statement, is designed to compare the effects of treatment based on ARB or calcium channel blocker on cardiac morbidity, mortality in patients with hypertension at risk for cardiac diseases. I'm sorry, it's not about the outcome wasn't about BP control, it's about the cardiac, okay? And so the hypothesis was that for the same level of BP control, valsartan would be better than amlodipine in the reduction of cardiac morbidity and mortality. So that's an alternative hypothesis, but you can see that it's very clear. You know, the objective talks about the outcomes, talks about what's being compared, you know, what kind of patient we are having, you know, patients with hypertension and at high risk of cardiac disease. Right, another one that was done by a local group that's very well respected for their GI work. So this one is looking at the eradication of H. pylori before NSAID treatment to prevent ulcers. The objective was to investigate whether the eradication of H. pylori, which is the intervention here, before starting NSAID, okay, reduce the occurrence of ulcers, the outcomes, okay, in this particular group of patients. And they hypothesized that the underlying infection with H. pylori can increase the predisposition of NSAID users to ulcers. Okay, so it's very clear, you know, objective and the hypothesis behind it. And you notice these two statements are usually not completely different. Okay, the hypothesis and the objective. The hypothesis is really the question that they are wondering. Okay, but they use this objective to prove it. All right, common problems that you might see, or common problem that we commit ourselves, it's something like that. If you read this, you notice this particular one, we evaluated the efficacy and safety of mycophenolate with prednisolone versus the cyclophosphamide, okay, with prednisolone. Notice this is a lot less clear. You know, it gives you an idea. It's not too bad, but you can almost guess this is more like a pilot study rather than an actual, you know, hallmark milestone trial. And there's no hypothesis here. All right, so now why don't we take a break and I will make you answer some uReply questions. Right here. Well, you're taking a break from me talking, but you still have to stay here.嗱，咁呢啲 you reply questions 咧，你哋唔使影相嘅，你哋更加唔使抄低啦。我遲啲會俾翻一個 copy 你嘅。咁點解其實我自己覺得 literature evaluation 咁重要咧？另一個我諗大家可能將來會考慮嘅就係 at some point 可能你會考 BCPS 個 board certification。其實 BCPS 個 exam 咧係好多 literature evaluation 嘅 questions 嘅。係，就算佢話 suppose 個 part 係 about therapeutics， 但係佢都係加咗好多有少少一啲 literature interpretation 嘅題目。所以如果你 literature evaluation 係好嘅咧，其實你嘅成功率相對又會高啲咯，係咯。所以呢個都真係緊要。如果你有問題或者你聽唔明啊或者唔識咧，咁你真係要話俾我聽 stop， 我等我再解釋。咁啊，睇下呢條啦，有同學揀 A， 有同學揀 B， 有同學揀 D。OK， 睇翻啦。OK， so obviously something that actually happened, and we actually did do this project too, to look at the impacts of rosuvastatin switching from atorvastatin. So the objective A, B, C, D， 咁正確嘅答案咧就係 D 嘅應該。咁點解係 D 咧？因為第一你唔可以 predict direction of the study effects 啦，係咪啊？咁唔可以講 cost saving 啦。So B and C are definitely wrong because it's saying cost saving. Okay, and then what about A versus D? 點解有唔同啊？而家大家睇得出個唔同未啊？個唔同咧就係個 focus 擺喺 switching。OK， 個 focus 唔係擺喺真係 comparing the safety and efficacy， 係要擺喺個 switching 嗰度，因為佢呢個 intervention it's about the switching, right? So D would be a better answer. All right, so 可以做埋下一條啊。sorry， 呢個應該係 diet 啊 ，hypocaloric diet。 好，睇下同學揀咩先。OK，有啲同學揀 E，有啲同學揀 D，有啲同學揀 C，全部都有人揀喎啊。OK，all right，好，大家睇一睇個 answer 啦。A ethical concern，點解會係 ethical concern？即係可能大家係覺得有一班已經咁肥嘅病人，咁你再俾 placebo 佢，係咪唔 ethical？係咪咁諗啊？Well，咁啊當然你哋嘅 concern 都係啱嘅，但係咧你要睇埋咧就係 plus a mildly hypocaloric diet, exercise and behavioral therapy to both groups， 即係話兩邊其實都有呢一個 lifestyle modification， 即係話嗰個 placebo group 其實佢哋都有啲嘢做緊。At least 多過 placebo 噶啦 ，OK。An even baseline demographic distribution, this would not be a concern at this moment because we are having a pretty large sample size. We talk about 540 people, okay? So this is a fairly decent size. And it's a randomized controlled trial. So you wouldn't need to worry about the uneven baseline demographic distribution as the first thing. Significant dropout anticipated, that's a possibility, but I don't think we have any particular piece of information in the question that points towards there's gonna be a very high dropout. 呢個係可以係都係啱，但係我唔會揀呢個為個答案，因為唔係最大嗰個 issue。Okay, unsuccessful patient recruitment, this is also ungrounded。即係你唔係一個好 strong 嘅 reason 啊，喺個題目度。反而E 個答案 unsuccessful blinding 點解啊 ？From what? Why is there a possible unsuccessful blinding? Or quite likely, I would say. Because of what? Because of the side effect. Very good. All right, so obviously, when you have drugs that have certain unique side effects, you will need to be careful. What are you evaluating a real blinded study? They call it double-blind study, right? So that's something that you want to be careful about. You know, are they really? It doesn't mean that the result is unbelievable totally, but then you need to be aware of it. And then when you do a lot of pharmacist intervention study, oftentimes you really cannot blind. Okay, so that's another thing. You might not always be able to blind in a lot of studies. Okay, so next, let's come back to our 使唔使 break 啊？又唔使住咯，嗬，講多少少先啦。Okay, so now methodology assessment question, and again, this is trying to be giving you some background, refreshment from what you have learned. So when you assess the methodology, number one, you want to evaluate your inclusion-exclusion criteria to see if your study patients are markedly different from those that are seen in practice. Was the sample size estimation done? Okay, was the power set at least 80%? Does this study have enough power to detect a difference that truly exists? Come back to that, okay? Did the randomization result in equal chance of being assigned to any group? In other words, was the randomization done well? Sometimes it's really hard for you to tell that because they don't tell you a lot about how they randomize, okay? But at least you will evaluate the patient demographics to get an idea about the two groups. Are they similar enough? Was the control a logical comparison? You know, placebo, standard of care, are these good controls? Okay. Were there differences in the way that the two groups were treated besides the intervention? You know, were there other things that could have affected the outcome besides the intervention? Were your subjects truly blinded, as we mentioned? And the follow-up outcome assessment, were they identical? Could bias have been introduced through any data collection or instruments as administration? So any bias that we've mentioned before, was there any follow-up study time frame sufficient to get meaningful results? Did you allow enough time to show the effects. Okay, A1C could be a good example. You know, if you are looking at, say, antidepressants effects, obviously, again, you would need to give at least several weeks to months to look at the effect instead of, you know, within a week or two. So consider the primary effects, side effects, symptoms, regression, remission, recurrence, survival. You know, some studies are so short that they really don't give you enough information about how sustainable those effects are. All right, so back to the study design. Why am I mentioning it again? Because I have seen so many student projects that don't even have a study design. Okay, and in a methodology, usually the first statement you should see is the design of your study. You know, is it a randomized controlled study, or is it non-randomized control? Is it a quasi-experimental, so on and so forth. So you need to at least make clear what your design is. Okay, then the next thing, it's about the quality of your participants. You know, the major characteristics they have, inclusion, exclusion criteria. You will assess the study sample, whether it's representative of the population, how severe are their diseases, any factor that can affect the treatment outcomes. Okay, and study patients who closely resemble patients seen in practice would be ideal. In other words, when you do your own projects, you hope that you try to recruit, or you try to have a relatively broad inclusion criteria. Okay, not too narrow, not too strict, because you don't want to be too selective and your patients became very different from those practice ones. And obviously the practical consideration is, are you going to be able to recruit very selected patients? It might take you forever to reach your sample size. Inclusion criteria, you know, just some examples here, you know, what I usually considered. And what I wanted to tell you here is a lot of students don't understand what's the nature of this. You know, it's you include all these patients that you describe. It's an and criteria. Okay, they have to have all of these, a certain age, a certain stage of disease, and having a certain disease marker. So these are and criteria. Okay, now exclusion criteria would be an or criteria, meaning if they hit any of these patients would not be able to join the study. Okay, so these are or criteria. Now, what about patients who refuse consent or refuse to participate? Should you put it under exclusion criteria? Yes or no? Yes or no 啊？大家會唔會擺 refuse consent 喺你個 exclusion criteria 度啊？ Yes。其他同學咧 ？No， 有啲同學 no， 有啲同學 yes。Oops， 哇，好快 miss 咗一個。好，嗱，嗰個 logic 咧，其實就係咁嘅。你先咧用 inclusion criteria recruit 咗一班人。你再喺裏面咧就再揀，睇下佢會唔會中咗 any of your exclusion criteria。refuse consent 嗰啲人咧，其實咧你唔係 exclude 緊佢，係佢唔同你玩。OK， 佢唔同你玩嘅時候，其實唔係你揀去 exclude 佢咯。OK 嘛？所以我會覺得咧，其實係唔應該將 refuse consent擺喺你個 inclusion，擺喺你個 exclusion criteria 㗎。refuse consent 你真係可以 recruit 佢咩？你點都冇得揀㗎啦。所以我會覺得 logic wise 咧，其實係唔應該 include， 唔應該擺喺 exclusion criteria 嘅。我會覺得好怪咯，因為唔係你 exclude 佢，而家係人哋唔同你玩咯。OK，so would that be considered drop out？ 呢啲咧就唔係 drop out， 因為佢喺呢一刻，如果佢已經唔同意參加嘅話咧，其實佢從來冇入過你個 study 嘅，咁佢就唔係叫做 drop out。drop out 係喺中間途中忽然之間你揾唔到佢，佢唔翻嚟啦，嗰啲先為之 drop out 咯。OK， 所以咧嗱個 logic include 然之後揾睇下有冇中咗呢啲 criteria exclude。OK，refuse consent 唔係屬於 exclusion criteria 嘅。好多人咁樣寫，但係我覺得你應該要搞清楚其實個 logic 個 concept 咯。OK， alright， so now randomization. Again, you have to understand this first. Why do we randomize? When you look at the study results, if there is a difference between the two groups, there are several possibilities. Number one, the intervention really exhibited a real effect. So that's one possibility. And the other possibility is the outcome difference is solely due to chance. What do we mean by is due to chance? 咩叫做係 chance 咧？咁啱得咁巧啦，即係咪啊？咁啱得咁巧。咁我點 define 係咁啱得咁巧咧？就係如果你重複呢一個 study 100次，有多過5次，你個 result 係唔同嘅，咁咪為之咁啱得咁巧咯，得唔得啊？嗱，一定要知道呢個 chance 嘅 concept 嘅，你一定要知道咩為之 chance。chance 即係話，即係咩叫咁啱咧？就係當你重複做一樣嘅嘢嗰陣時，可能個結果係唔同嘅，咁就為之咁啱咯。明白嘛？好生活化啦，希望呢一個諗法。Okay? So why do we have this p less than 0.05? It's basically saying if you repeat this study 100 times, if less than 5 times you're going to get a different result, then your result is significant. It's very likely to be real. It's not just by chance. Okay? All right, so that's the second possibility. Okay, the outcome difference is solely due to chance, but unfortunately, you know,你咁啱中咗個5次嘅其中一次 ，OK， 即係話你其實 repeat 係會有一個唔同嘅 result 嘅 ，OK。All right, number 3, the difference between the two groups were due to factors other than your intervention. For example, some baseline differences like identified risk factors or patient variables, or due to something that is unidentified. Okay, or sometimes some confounding factors that you weren't aware of. Okay. Baseline differences, why do I differentiate it from unidentified? Because I'm thinking about the baseline demographic table, the table 1. That's usually in a study. Okay, so there are identified risk factors and unidentified risk factors. Identified ones, at least you can still look at it and evaluate the effects, evaluate the difference. But in fact, there are many unidentified risk factors that, you know, could be having an effect. There's no way for you to capture it if it's not identified. So again, when you see difference, could be due to a real intervention effect, or it's just 咁啱得咁巧，咁好彩，今次見到一個 difference. Or the difference is due to other things that's, you know, could be your own patient factor, you know, your confounding factors instead of the actual intervention. What randomization does is to help to ensure the groups are as alike as possible, okay? Because now you hope to assign them, you know, into the two groups and their distribution is even. And you hope that this distribution is even for both the identified risk factor, which you can measure, you can look at it, you can evaluate, but also the unidentified risk factors. Although you cannot see it, but you would assume that randomization probably can help you to even that out, especially if your patient size or your population study size is big enough, then very likely everything would be quite fair and square, evenly distributed. So successful randomization is very helpful because it allows for valid statistical interpretation. It does not guarantee a perfect balance in risk factor between the two groups, okay? Because there are occasionally chances, and then the adjusted analysis can help in further interpretation of your study outcomes. So to do randomization right, what you look for is a sequence generation description, the method that is used to generate the random allocation sequence. Okay, there are a lot of tools out there. You can use a statistic
textbook, or you can just use this website www.randomization.com. It can generate sequence based on your sample size, based on how you want the block, etc. Okay, so they generate, they use a seed, then they give you a seed number that you can always go back to look at this sequence. So allocation concealment is the next thing. Once the sequence is generated, you need to think about how is it going to be implemented. So the method that's used to implement this random allocation sequence, is it hidden from those study investigator? Okay, so you will want to clarify whether the sequence was concealed until the interventions were assigned. Okay, clarify if people don't know what the next patient is going to get. Okay, why is that important? Because if you know whether your next patient will be intervention or control, in fact, you can manipulate. You can sort of manipulate who gets your intervention, who doesn't, if the allocation concealment was not properly done. Implementation, who implements it, who generate the sequence, who enroll the participants, who assign participants. Now, these are more important, especially when you're looking at like a study that sets its blinding. It's double blind, single blind. Then you want to check this to see if it's really a properly done kind of blinding. All right, sequence generation. This is also another thing that confuse a lot of our students. What is randomized? What is not? 點樣為之 randomized 咧？點樣為之唔係 randomized 咧？ Group assignment should not follow a simple predictable pattern if you are aiming for randomization. Alternatively assign 即係話第一個 intervention， 第二個 control， 第三個 intervention， 第四個 control. Alternatively assign, that's a simple predictable pattern. This is not a randomized control trial. You probably would call something like that a non-randomized control trial if you're alternately assigning your patients. What about odd and even day admission? Also not consider a randomization. Okay, it's also kind of following a predictable, a known ahead kind of pattern. Simple randomization is just using some computerized generated numbers. The randomization.com I just mentioned to you could be a simple randomization way. And those random numbers from statistical textbook and also a good way to do simple randomization. 好，我諗我要俾個 break 你哋，因為跟住開始講嘅嘢咧就開始有啲複雜㗎啦。So what about a very quick 5 or 10-minute break now? We come back at 4:55. Oops. 好，同學有冇問題啊？有冇地方唔明啊？All right, so I guess I can continue. So the next topic we are going to venture on, it's the permuted block randomization. I'm sure you heard a lot about block randomization. What is block randomization? So basically, this is how the blocks looks like. You'll first generate this random number sequence, okay? And each block will be pre-designed to have either intervention or the control. A being intervention, B being control. So if you were to follow the random number sequence 1 first, then you would go for AABB. So your first 2 patients will be, oh, 死啦 咦死啦 sorry 喺度 all right. Sorry, let me go, then maybe I go back a little bit. It's not rocket science though. So block randomization, something you hear often. Okay, so right here, first you have a random number sequence, okay, from any of your random number sequence textbook or software. So each sequence or each number would be assigned to a pre-designed block. Okay, the permuted block right here. So 1 means AABB. So let's say if the sequence is gonna be 1, 4, 6, 5, like this, 1, 4, 6, 5. Then your first 2 patients that come in will go to group A, which is intervention. Next 2 will go to group B. And then your next sequence number is 4, and then, so the following 2 patients will follow the assignment of number 4, which would be B, BAA. So intervention, intervention, control, 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 intervention, intervention. The good thing about using these block randomization is it makes sure that your number of patients in each group wouldn't deviate too much, because you notice like number 1, you're going to have 2A and 2Bs. Same thing applies to other numbers, okay? And then number 2 is you can do more fancy things with this block randomization. For example, the stratification. Stratified allocation means you use a set of the block generated for combination of prognostic factors. So one example here, let's say if in a study we care about the gender and the age, we want to make sure that people of the same age, same gender will be equally distributed between the 2 groups, okay? So example, age less than 60, age less than more than 60, and the 2 genders. That will actually give you 4 stratas, okay, 4 stratas, and then with 4 blocks needed, okay. That ensures that your patient with and without those factors are randomized to both sides of the treatments, or to make it more straightforward would be patients with those factors are randomized to both sides equally. Ensures that the treatment balance of these prognostic factors, it adds to credibility of a trial. Now, why is this so helpful? Because when you have a small study and you want to ensure that your baseline characteristics are quite similar, using those stratified randomization would help you. On the other hand, though, if you have a huge study, 萬幾人嘅, okay, large study, most of the times these patients will be quite similar, because a large sample size would tend to give you more even distribution. So they might not use block randomization. It might not be necessary if the study is big enough. And why is it helpful? Because if your 2 patient groups are balanced, now you have less confounding factor that could have affected your outcomes, okay? But you might notice, oh, you actually cannot do too many of these. Most studies would go with like 4 strata, no more, okay? Not like 40 strata Although there could be many prognostic factors that are important, but you wouldn't go for many strata because that will make it very complicated. Okay, so I guess the drawback is there's only so many blocks you can have, or there's only very few strata you can have encompassing those prognostic factors. So here's what we just did. Okay, taking the same strata that we just mentioned, 1, 4, 6, 5. If this particular study is trying to make sure that people who are obese and smokers are equally distributed between the two groups, okay, what they would do is first put patients into BMI more than 23 or less than 23. The other thing, it's about smoking. Okay, smoking, non-smoking, smoking, non-smoking. Okay, so your first strata, 1, is when BMI is larger than 23 and smokers. These are the high risk group. So these patients, by drawing the random number, let's say, these patients are found to follow block 1 first. Then remember, block 1 was AABB, right? So the first 2 patients that meet those 2 criteria would go to group A, which is intervention. Second one, the same, intervention. Now the third one should be a B, so it would go to the control. Okay, the fourth one also go to the control. Now the next strata that these patients follow could be a 4, could be a 6. The number can be drawn later on so that it won't be predictable. Okay, as long as there's a lot of good paper trail, it wouldn't be confusing. Okay, but now you can see these patients who bear these major risk factors are going to be equally distributed between the 2 groups, right? Does that make sense? 大家明唔明啊? Okay, 嗬? That's how it goes. All right, so I guess you guys understand that, right? So let's move on to the outcomes. Outcome variables needs to be very clearly defined. And you also would need to define the amount of differences that your study can detect. Okay, so first of all, how do these outcomes get defined, or what are the things that need to be defined? If you see an outcome that says, we're going to look at the treatment of hypertension. Now, this is obviously very unclear. Okay, you don't know how it's defined. Versus if it's saying blood pressure changes or blood pressure control, now you have an idea the parameter is going to be blood pressure. Okay, so should be something measurable, quantifiable. It should be described how they are measured, like the timing, when is it drawn, the instruments that are used, any particular technique that is followed. Okay, so all these need to be clearly said about those outcome variables. If it's a subjective outcome, then the literature can support the validity of those questionnaires or those scales would be quoted. Okay, usually you don't make your own subjective criteria. Okay, you would try to find existing literature or existing scales so that what you are measuring is considered more reliable, well validated. Okay, so better to use previously validated tools or assessment scales. And in fact, even language is another issue. Unfortunately, in our local population, a lot of times we don't have order scales in Chinese, and sometimes translation is needed. But in fact, translation itself can make another study. Okay, it does need a lot of validation, back and forth testing. So I would suggest you try to, if you do your own project, try to find something that had been used before that's also available in Chinese. If you are using it for patients, with direct patient interaction, you want to make sure your patients understand, because you have to follow the exact wording when you ask the questions. All right, so now, next big topic, it's sample size. Okay, I'm not going to be able to show you how you calculate your sample size, but I want to show you the important things that you need to consider when you come up with your own. And then the biostatistician will show you the actual steps. So how is sample size determined? First of all, it's focusing on your primary outcome. Okay, if you have a lot of secondary outcome, other outcomes, a lot of times those are not things that are most important to your study because it was not designed with a proper sample size calculation. So sample size calculation mostly for or just going towards your primary outcome. So several things that are in your formula: power, the level of significance, the underlying event rate in the population. In other words, how common is your outcome? If it's something that is very common, congratulations, you will usually need less patients. If it's very rare, obviously hard for you to detect a difference. Okay, so you would need a larger population. The size of the treatment effect that is being sought. Okay, if you are looking, or if you can, if you're only wanting to say a large treatment effect is statistically significant, then great. Also, you will need less sample. Okay, but that you also need to think about: can I create such a big treatment effect? Okay, we'll come back to this with examples later on. And then finally, the last couple things to think about is the compliance rate. And do you need to have an unequal allocation of ratio? Okay, so look at this. Not a real equation, but then it shows you the relationship. Here's your sample size is proportional to power. In other words, if you want higher power, the ability to find a difference, if there really is a difference, if you want to have a very high power, very sensitive to finding differences, then you need a larger sample size. If you are looking for a large effect to detect, let's say I don't care about small effects. I only want to say large effects are significant. Then again, it's inversely proportional to your sample size, meaning you will need a smaller sample size if this is larger. Event rate, I think we have mentioned this. Higher event rate, common outcomes. 譬如你個 population 好多人有 cancer 嘅 okay? Then your sample size would be smaller than in a population that cancer is extremely rare. And then alpha, same thing. Larger alpha, you need a smaller sample size. Okay, so now let's go into this in a little bit more detail. So power, we've mentioned this is the ability to detect a true difference in outcome between control and intervention. Larger trials usually set it at 90% to reduce the possibility of a false negative. Okay, meaning there is a difference, but you said there's no. Okay, so missing a real difference, or sometimes false negative is called a type 2 error. Power equals to 1 minus beta, which is your false negative. So one example statement that you might see in literature, it's in this particular study, the OHAD study that compared different antihypertensives in heart failure. They actually found that OHAD study had an 83% of power to detect a 16% reduction in risk of the primary outcome between clothalidone, which is a diuretic, with the other, there were 4 different arms at a two-sided alpha of 0.01. So you might ask, oh, why is it so awkward? Why do they have 83% but not like 80% or 90% or 85%? Now, usually in these large trials, their sample size estimation, they use softwares. So they use software so that they can have the power on, say, the y-axis, and then they would have the alpha on the x-axis. So they basically, they try to balance these two to get the highest power and not too big of an alpha. But that's how they don't always end up being like a round up number. All right, so understand the power, ability to find difference if there is. Okay, now the level of significance, this sets the error acceptance rate, the error of calling a treatment effect in the study, while there could be no difference. Okay, so your false positive, it's right here, false positive.
calling something significant while actually it's not. In other words, this is also your chance finding. Okay, so commonly set at 5% or 1% as the threshold. If it's set at 5%, that means you are prepared to accept a 5% chance of erroneously reporting a significant effect. So whenever you see, let's say your own project, you set the alpha at 0.05. That means you are actually accepting 1 in 20 times that your result is actually not significant, but you call it significant. 咁其實即係話個 P 咧，有陣時你見到可能係0.03，咁即係話咧，其實係3% 嘅可能性咧，你而家話佢係 significant，但係其實佢唔係嘅。Okay, or it's not a real difference。你再做呢個 study 嘅話咧，100次裡面有3次你會揾到一個唔同嘅結果嘅，就係咁解啦。Okay, so if I guess basically this part is trying to set your error acceptance. Most people accept 5%. Some people accept 1%. Okay, so if it's 2%, then in those situations, it would be considered non-significant. You're not accepting this as a significant result. Okay, so when the P is larger than alpha, you are saying that the difference may be due to just chance. Okay, and then if P is less than alpha, you reject chance and say this is a significant effect. If I repeat it 100 times, I'm going to see a different result in less than 5 times if you set it at 0.05. What about if P equals to alpha? It's also a good news. It can reject the chance and say this is a real effect. All right, next, it's about the underlying event rate. Where does that come from? It's established from the previous studies. You consult the other studies that have been done in your, let's say in the control group, then you will get to see what is the event rate. 喺 control group 即係你當佢 almost 係個 general population， 有幾多 patient 係有 stroke 嘅，有幾多 patient 係有MI 嘅。So this is the underlying event rate, based from the previous study. Overestimation can occur because there could be many differences in population practices. If you overestimate the event rate, that means it's actually rare, but you thought it's more common. Then you could be in trouble because your sample size may not be able to detect the difference. Okay, your sample size may not be big enough. So sometimes ongoing trials will allow for sample size adjustment, meaning that if they notice the event rate is actually less than what they expected, they will adjust the sample size to recruit more patients to ensure that they can still have enough power to detect the difference. Now, on the other hand, if you have underestimated your event size or event rate, then good news, you don't have to do anything. Sometimes you can even downsize your study, but it's basically a good thing because now it's easier for you to detect a difference. What about the size of treatment effects? This is the smallest worthwhile difference in response. Okay, could be determined from studies or expert opinions. Now, how does that become tricky? Some students would say, oh, how am I going to know about my effect size? How am I going to know how good my intervention will be? How good my interventions change the outcome. For example, hemoglobin A1C, 1% or 0.5% or 0.25%, right? You will need to use this number for your sample size estimation. If you read a lot of pharmacist intervention studies, you look at the results, you're going to have an idea about, in general, how good pharmacists are in reducing A1C. You're going to see a lot of times people can actually achieve 0.5 to 1% of A1C reduction just from pharmacist intervention. Okay, so with that, you will use it for your own projects as well. You can put in 0.5%, then you will need a larger sample size. If you put in 1%, then you will need a slightly smaller sample size. But if you fail to achieve a 1% A1C reduction, your intervention isn't as good as those other studies, then what is going to be the outcome?
your result might be non-significant. Say if you achieve a 0.7%, but you preset that you need to achieve a 1% in order for it to be called significant, then your result might turn out to be non-significant. All right, so everybody okay, right? You understand the relationship between all these different parameters and sample size. All right, so now let's look at something that's slightly different. Unequal sample size example. Some studies, they don't have the one-to-one design. In other words, the number of patients randomized to intervention is not one-to-one to the number of patients randomized to control. You might see 2-to-1, sometimes, occasionally, rarely, maybe 3-to-1. Now, why is that? There's usually some sort of ethical reasons, okay? Some sort of reasons making it not feasible to do one-to-one. One-to-one randomization allocation is always of highest power, okay? Highest statistical power. That means you actually need less patients in the entire study. OK， 即係話 one to one 嘅可能譬如500個 patient 就夠嘅。如果你係用 2 to 1咧，可能你要600幾或者700個 total。OK。Say that Olmsted study I showed you earlier, actually they had a 2-to-1 ratio. I think they had more patients in the active arm than in the control arm, if I remember correctly. Okay. So you can kind of imagine, oh, why is that, right? What are the common reasons leading to this unequal sample size example? It's usually due to maybe it's a new intervention, you know, that seems to be very effective, right? People want to get into the intervention group rather than in the control group, okay? So you might have difficulties in recruiting controls, sometimes in some supposedly great interventions or great new interventions. Then you might need to do a 2-to-1 to attract more patients to say yes, okay? Sometimes it could be for a training purpose, a new technology. They prefer to use more cases than the control. Now, sometimes it could be a cost. Maybe the new treatment is very expensive. We cannot afford to recruit so many patients in this intervention group. Then we might have more control than in intervention, which ultimately you will still have enough sample size, but you just have less intervention, okay? So let's look at this particular example. If you could have equal number of patients per arm, sample size calculation sets you will need to have 16 patients per arm, meaning a total of 32, okay? But somehow you can only recruit 12 patients in your active group. For example, this new treatment may be subjected to a lot of side effects. Okay, you have a lot of patients who refuse coming to the study because they worry that they'll get into the active group. Then you can only recruit 12 patients in the active group. Then how many patients would you need in the control? It's actually not one-to-one anymore, because now if you only recruit 12 patients in your control, you're only going to have 24 patients in total. You're not going to have enough sample size or power. So you have to calculate a ratio using this particular equation, okay? So the equation turns out, if you plug in, you know, the original one-to-one number here, N naught, it's the number of patients that you can recruit in the one of the groups, okay? You're going to come up with a ratio that's, in this case, it is a 2, okay? So it's going to be a 2-to-1 study. You will need 24 patients in your control group, 12 patients in your active group. Your total number of patients is now 36, which is more than 32 if your study can be 1-to-1. In other words, you need more patients to achieve the same power, same statistical power. But the good thing about it, obviously, is now you don't have to worry about not having enough patients in your active group. You know, you made it up by having more control to give you the statistical power.
So just some examples for you to see. There are studies that very clearly articulate how they come up with their sample size, how they account for the dropouts. Okay, so in this one, let's look at this example. They estimated the sample size based on previous study that showed the ulcer prevalence was 33% in their NSAID users. Versus a 6% in the NSAID users who don't have the H. pylori infection. So you have your underlying event rate, and also to a certain extent, you have your the effect size you are looking for, right? If you look at the difference between the two. So to achieve a statistical power of 85% with an alpha of 5%, they calculated that they only needed 45 patients in each arm. So they did consider the fact that people might drop out, and they were using a 10% dropout. Now, this is a more aggressive number, meaning that they are estimated a very low dropout rate or dropout percent. Now, this really depends. Sometimes it depends on how long your study is. If you have a longer study, then you will need to worry about a higher percentage of dropout. People don't stay, okay? So they did, this is a total of 90, and then you add on 10% to it. They calculated that 100 patients were actually required for the study. This is a very common way of doing or accounting for potential dropout. Just add that percentage to your total number. Okay, but in fact, if you want to be safe, what you should do is actually to consult this particular equation for the adjustment for compliance, because the reduction in power actually is not proportional. Okay, what they just did, it's more like easier so that they don't have to recruit as many patients. Okay, it's not the ideal way. The ideal way, if you really do carry out this calculation, you're going to see that they need a lot more than 100. They actually will need a total of 145 or 150, around that number, to make sure that if there's 10% dropout, they still have enough power to find differences. So realistically, many patients, because it's so difficult and so costly to recruit patients, it does take a lot of resources. So a lot of people just go with the simple way and just, keeping their fingers crossed that they won't lose so many patients. So the sample size should be determined before initiation of the study. Okay, some studies they would do after study sample size justification. It's not as good. The most important thing is sample size should be predetermined. You can make adjustment or you can justify later on if there were changes, but do estimate ahead of time. If there's inadequate sample size, unfortunately, it's almost a waste, okay? Because your results cannot directly influence patient care, and oftentimes just consider a pilot study that doesn't really drive treatments. So next is the interim analysis. Okay, interim analysis is also something that maybe we don't do, but the big studies tend to do this. What they do is they evaluate data at multiple time points during the investigation. Say like a 3-year study, they might have 7 or 8 interim analysis time point. The purpose is to ensure that the study was ethical. Let's say if during the first 6 months of the study, they already found the active treatment is super powerful, it cured a lot of patients, then it becomes almost unethical to continue the study, because you are leaving half of your patients in a control, not giving them this super drug. Okay, so interim analysis is trying to ensure there's ethical practice, but it also has its own problem because the data may be collected at a random high. And oftentimes with these interim analysis, the safety and efficacy results are exaggerated. Okay, so the results are exaggerated. Why am I saying that? Because if you think about it, if you preset a point that is very saying, let's say a drug that is curing 10% of cancer, lung cancer, okay, you set it at 10%.
maybe at some point your data will hit this 10% mark. But does it mean this 10% will continue and be maintained? It may not be, right? There's a good chance that it might go down back to 5%, 2%. There are fluctuations, in other words, during the study. Some people, during a particular time period may be doing better, okay? If you just caught that time and say, hey, this drug is super helpful, let's call this study an end, then you could be just taking one particular time point and not seeing the actual outcome. So the dilemma here is you want to safeguard interests of patients in the placebo arm, but you also want to protect the society from some premature efficacy claims. Here's one example that I think it's pretty interesting. There are multiple studies, big studies out there that might have been stopped prematurely, but ever since people noticed that could be a problem, there are a lot more careful practices. In this particular study, there was a CHARM program that they basically looked at the use of an ARB in heart failure assessment. There are 3 separate randomized controlled trials within the research program. They look at all these patients, different groups. Now, the key thing here is there were significant treatment differences in all-cause mortality in the overall program at several interim analyses. So they saw significant differences. And at one point, the result actually reached the stopping criteria, that preset criteria for stopping this study when the benefit is too significant, okay? However, they also observed that, there were some conventional levels that weren't completely achieved in all the studies. So the data monitoring committee actually recommended that although we hit that pre-specified point, let's just continue this study instead of calling an end. Okay, so they just continued despite that particular percentage of benefit was hit. Final published result for the all-cause mortality at 3 years was 9%. And guess what? It's actually not statistically significant. It's borderline, okay? Although there were certain other parameters that were significant, okay? And then they kept on looking at the pattern, and what they found is in the first year, the hazard reduction was most significant. But after that, those benefits actually kind of, got even out or, kind of regress to something less dramatic. Okay, so this is one example of where a very careful studying of those data by the data monitoring committee is very important. What those committee also usually does at the beginning is they preset criteria for early discontinuation of study. So when you do your own literature evaluation journal club, sometimes you will see if you caught a big study, you might see that they would say, consider the primary outcome and other efficacy outcome, safety issues, okay? Also, besides just their preset criteria, okay? And what is usually this preset criteria? It's quite straightforward. Usually they set the alpha or the p to a more stringent number. Okay, p less than 0.001 is suggested in this Haber-Peto stopping boundary. Versus the other boundary, sometimes they suggest something that is slightly more stringent than 0.05. They go for 0.02. But 0.001 is usually the more common one adopted nowadays. Ultimately, you want to prevent the risk of overestimating the effect of an intervention. Okay, sometimes it's really just because it was caught at this random high. All right, any questions so far? So why don't we take a, I guess, in a way, a break back to our uReply questions.
好，睇下同學揀咩先啊？有同學揀 B， 有同學揀 C， 有同學揀 D。B 就係 the study investigators are potentially biased。OK，C 就係 quality of life should not be solely based on self-report. Family report should be added. Okay. Placebo is not the most appropriate control that should have been used. 我自己揀嘅答案咧就會係 D 啦。Placebo is not the most appropriate control because these are patients with moderate to severe ADHD. When you look at the comparison, if you're comparing this drug, potentially a new treatment for this patient population, if you're comparing it to placebo, it's almost, number one, unfair as a comparison because there is already a drug that has been approved, which is atomoxetine. I would think that they should compare it to atomoxetine. Okay. And also, second thing is, would there be an ethical issue that needs to be considered? It's potentially unethical for these moderate to severe patients. Okay, now obviously B, it's also correct. Okay, the study investigators could be potentially biased because you do have this sponsorship from the manufacturer. But this is, I don't like to just say this is the biggest, the most important critique, because after all, you should look at the study itself to say whether that was really a well-designed study. A lot of people receive grants from drug company. It doesn't mean that they are bribed. It doesn't mean that they are not doing the right thing. Okay, so I really don't like it when we just go blindly to say it's the investigator's bias. You really have to look at the study, evaluate it to say, okay, there are potential problems, which are, All right, so next. OK， 有同學揀 A， 有同學揀 B， 有同學揀 C， 咁我哋睇下先。好多揀 A。嗱呢一題咧，首先你要知道咩係 internal validity， 乜嘢係 external validity 啦。咁我啲同學可唔可以答下咩為之 internal validity， 咩係 external validity 啊？咩係 internal validity 啊 ？external 先啦 ，external 好容易講啫，係咪啊？我等緊啊。Okay, good. External means whether the study can be applied to the settings outside of your study. Good. All right. What about internal? Okay, was the study done right? Basically, yes. Was the study able to answer the question they asked? Okay, did it recruit the right patients, for example, in order to answer that question? So I would probably choose C in this particular case because the type of patients you recruit would affect whether you can answer the questions that you set forth to ask. Just like the example we saw last time, remember, are you recruiting the high-risk patients in order to show a hospitalization difference, right? So I would probably pick C in this case. If you pick A or B, you're correct too, but I guess if I look at it, I think both are relevant. Okay, next. OK， 好好喎，好多同學揀 D，冇錯啦。咁咦，大家係識嘅喎，點樣由呢個 confidence interval 嗰度去睇個 significance？OK，呢個非常之好，咁我哋可能可以講得快啲啦，呢一部分。咁下一題咧就係 related 嘅。你嘅答案應該都係冇變嘅。OK， 好，大家仲需唔需要 break 啊？需唔需要 break？OK， 哇，好啊 ，no 啊，好啊，好，咁我哋繼續啦。So far 有冇問題啊 ？Oops。Okay, so the next thing that we're going to go through is the results. So when you assess the results, there are actually many things that you need to consider. Were the study and control groups similar at baseline? This is the table, the table 1 that I tried to refer to earlier. Were they similar at baseline? Were there deviations from the protocol? Okay, are they including things that they didn't say they were going to investigate? Was there reasonable compliance attained by your subjects? Did compliance differ between the two groups? Adverse effects, was it reported? Okay, were there all patients accounted for? Was there any dropouts? Does it differ between the two groups? Were all the patients analyzed by the intention to treat analysis? Now, depending on the study design, intention to treat may not always be the only thing you need to do. And we'll come back to that later on.
Are the confidence interval and p-values provided and accurately interpreted? Did the study meet the sample size requirement? Are the results clinically significant? I think you know about the clinical significance, but you also need to judge whether something is considered clinically significant. Are the significant results generated from subgroup analysis? All right, so now results. Now, when you find a study really hard to understand, actually, it's usually not your problem. It's the study investigator or the author's problem. If it's so hard to understand, usually it means it's not done right. If you pay attention to those big, good journals, usually they're pretty good to read. Okay, easy to read, very clear, not too many outcomes. And by the way, I do want to point out for your own journal club, you don't have to find something crappy. Rather, I want you to find something that is relevant to the topic assigned to you, and something that you find that maybe you can learn something. I don't want you to find those really small, crappy study. In the end, you don't learn anything. Okay, so you can feel free to get really good study. You know, there's always something to criticize, even in good study. Okay, so bear in mind that. And in fact, for some disease topics, the facilitator actually had articles that they want to recommend to you. So I will also post this later on and let you know about it. All right, so back to the results. Besides the efficacy result, usually there should be some mentioning of the adverse effects too. The data in the abstract, chart, text, figures should all be consistent. So when you find mistakes, basically, oops, maybe these investigators are not very trustworthy. And same thing with yourself. You want to make sure that you don't do it in a rush and you made too many careless mistakes. Mathematical tabulations for charts, tables should be accurate. Okay, so flow diagram. Flow diagram is needed even in your own project. This is a standard required in the consort statement that clearly delineates the number of patients who are assessed for eligibility, the number of patients allocated to the two arms, and why are some patients excluded, the reasons for exclusion. This is where people will look at to see, are you excluding people based on your exclusion criteria? And then the follow-up, you know, how many patients were lost to follow-up? Hopefully that would be even between the two arms. And the reasons for that and the number analyzed. So you have a lot to collect if you were to do your own projects. Another example here, you know, a lot of times this kind of table also gives you an idea about how many patients were excluded. Were there a lot of patients being excluded, making your results maybe not very generalizable to a big population? All right, next, a very important concept that I need to make sure you understand so that you can follow me. First of all, what is a difference, or what do we mean by a real or true difference？ 即係咩叫做 difference 咧？點樣為之一個 true difference 咧？每次你見到一個數字同另一個數字，其實都有一個 difference 嘅，係咪？但係呢個 difference 係咪一個 real difference 咧？就係我哋而家講緊嘅問題啦。Now, a real difference， 一啲嘢係真嘅咧，就係when you repeat it 100 times, you would expect most of the times you should get the same result. Okay? 咁就為之係真嘅。個 reproducibility defines it's real. Okay? 咁有咩時候你可以將同一個 study 做100次都可以攞到一樣嘅 result 咧？唯一嘅時間其實就係如果你可以 recruit 晒成個 population 啦，即係假設香港有100萬人有 diabetes 嘅，如果你做一個 pharmacist intervention study， 你可以 recruit 晒呢100萬個人喺呢個 study， 無論你做幾多次，你都會係有一樣嘅 result 嘅，啱唔啱啊？因為你都係講緊同一個 population， 你不停咁做一樣嘅嘢。OK， 咁當然我講話一樣，梗係即係已經 allow 一個正常嘅少少 deviation 啦。 OK， 唔係話100% 一樣，只不過 very close。OK。But realistically, we can never enroll everybody into our study, right? We cannot enroll the entire population. Rather, we extract samples. Okay, so let's look at this example. If you have a study that's again trying to look at A1C reduction, and you took this small sample in the entire population, their baseline could be on average 10.9%. Okay, and then you take another small sample in the population. The baseline could be different, could be slightly worse. So let's say if you just took this group of patients, baseline it's 10.8. After giving them drug A, you see the A1C reduction from 10.8 to 9.6. There is a difference. Now the difference is 1.2% of A1C reduction, right? The question is this a real difference? So we try to repeat this study. And let's assume it's also drug A, okay? So if you were to repeat this study, you might find something that's different. Now it's no longer 1.2%. Now it's only a 0.4% reduction. Okay? So that means, oops, when you repeat it, you don't get the same. Now this is just the second study. Technically, you have to repeat it up 100% to see whether it's real or not. But realistically, you cannot repeat the same study 100%. I mean 100 times, because it's going to be way too costly. So what statistics does for you is they does it 100 times hypothetically, or using statistical method, they pretend that they did it 100%. Then they give you a figure. Okay? You considering the variation of your data set, you know, the variance, the distribution, things like that. So they use the statistical method to pretend that they did it 100 times. Then they came up with a number to tell you how many times they got the same result. So right here, you know, assuming that these are two separate arms, drug A and drug B, there was randomization. Unfortunately, the issue right here is the drug A group was worse at baseline for A1C. Okay, so the two groups weren't very similar to start with. And then when you look at the change, drug A group, it's 1.2% reduction. Drug B group was 0.4% reduction. Do you feel comfortable to say drug A is better than drug B? So you have to answer me in the chat box. Yes or no? Do you feel comfortable to say drug A is better than drug B? No. Okay, good. No, because the baseline are quite different. Okay. And the fact is, when the baseline is different, and right now we're just looking at one parameter. You know, there could be many other parameters that are different between these two groups too, and we're not even seeing the whole picture. And therefore, in those situations, you wouldn't feel comfortable because the two groups are so different. You have to have some sort of adjustment to tease out the difference. Okay, and we'll come back to that later on. So keep going. So now the investigators have more money. They recruit more patients, okay, a bigger population. This time, because you have a bigger population, you even out all these, you know, the unevenness, you know, or the variations of different people. You have a fairly similar baseline A1C and probably fairly similar parameters. After giving drug A, you get an A1C of 9.1, and then drug B, you get an A1C of 9.5. So essentially, if we're talking about the change, drug A induced a 2% reduction versus drug B induced a 1.8% reduction. So now the question is this 0.2% difference a real difference? And remember we said the definition of a real difference is the difference is not due to chance. When you repeat the study, you're going to find the same value. So if you look at this schematic diagram, if I were to ask you to repeat this study, you probably can guess that you might get a fairly similar result. Why? Because when you repeat the study, there is a good possibility that you might get the same patient because your sample size is very large, representative of your population. That's why when you repeat it 100 times, you're going to get fairly similar result because your people are overlapping or they are representative of most people in the entire population. Okay, so I hope you guys are all clear on this concept because it really helps a lot when you are trying to understand things. Okay, why is large sample size so important? What do we mean by a real difference? A real difference can be a small difference. What am I saying? You know, because with this 0.2% difference can be a real difference because when you repeat it 100 times, you're going to many times get the same 0.2% difference. 即係話個數值細唔代表佢唔係一個 real difference 嘅。Okay, real 只係話 repeat 係咪得到一樣嘅嘢嘅啫。But when it's more, you need to decide whether it's clinically significant. Okay, when it's small, you need to decide whether this difference worth the money for this new treatment. Okay, 點解你話但係點解我覺得好似如果嗰個數字大，即係嗰個 effect size 大嘅話，即係話有隻藥可以減到hemoglobin A1C， 譬如3% 咁樣，我覺得佢好似好 significant 喎。咁係咪即係話其實個數字大同佢係咪 significant 都好有關係咧？咁的確，如果嗰個 difference 係大嘅話，咁即係 very likely。當你 repeat 個 study 嗰陣時咧，其實起碼你都會仍然得到一個幾大嘅 difference。OK， 咁所以仍然都會係話都係幾 close。OK， 當你個數字係大啲，即係你嗰個範圍啊，可以俾你話佢係 very similar， 其實係大咗。而大家嗰個 overlap 會少咗咯，即係兩個個 confidence interval 嘅 overlap 會少咗。當你個數字大 ，usual 或者個 difference 大咯。係啦，咁我希望呢一個咧，係一個即係等大家清楚少少，我哋講 statistical significance 啦 ，clinical significance 究竟係講緊啲乜嘢？乜嘢為之 real？ 乜嘢為之唔 real？Alright, now the baseline characteristics. The purpose of it is to assess the generalizability, so you know whether you can extrapolate the result to your population. Also allows you to eyeball the success of randomization. Successful randomization doesn't give you 100% balance, but at least they are quite similar. Well-balanced baseline factors, that's implying the only thing different between the two groups is your intervention. And now you can deduce any difference in outcome was due to the actual intervention. Okay, so that's the beauty of randomization. So the factors that can influence outcome should be described in your baseline characteristics. Okay, any known factors, any factors that likely would influence it or benefit, modify any benefit should be included. Any factors that predict ADR. So let's say if you were to look at a study that treats acute stroke, then you would expect if anybody had hemorrhagic stroke before, needs to be stated in your baseline characteristic table, you know, predicting the ADR. Any factors that have been used as the strata, remember the prognostic factors we talked about. So essentially, this is really, besides the demographics, you also want to include anything that affects your outcome or that has an important treatment effect influence. baseline characteristics with successful randomization, your baseline characteristics should be quite similar except by chance, right? Because when we say randomization 即係本身就係一個隨機，係咪啊？你見到可能一 group 係65歲，隔離個 group 67歲，其實呢個 difference 只係 by chance 嘅啫，啱嘛？可能你再 repeat 一次個 randomization， 可能你會得到都幾可能有少少唔同，可能今次咧係 intervention 係67，個 control 可能65 ，OK， 咁有可能嘅 ，OK， the difference is really just due to chance. For continuous variables, assess the similarity by comparing the mean and standard deviation. For your categorical, you look at the proportion， 幾多個 percent 係男，幾多個 percent 係女。Age 通常係 continuous 嘅，有個 mean age, right? So, you know, depending on the nature of the variable, you will represent or present it differently. So next, it's a very commonly seen procedure is to test the baseline characteristics by using the p-value. And what I want to discuss with you is this something appropriate? My argument would be the p-value to assess the baseline characteristics is not the right thing to do if you're doing an RCT. Now, if you're doing an observational project or observational study, this is okay, okay? But with RCTs, it's not okay. Why? Number one, if you remember, we mentioned the sample size is designed based on your primary outcome, not all these baseline factors, okay? So technically, your sample size is only large enough to detect a pre-specified difference in your primary outcome. It could be way too small for all these baseline characteristics. If it's too small, then you're not going to find a difference, right? Then you actually cannot rely on your results. Point number two, by definition of randomization, all those numerical differences you're seeing between the two groups should be due to chance, okay? So if you're going to use a statistical significant test to test this randomization or to test these two columns of parameters, and say if you do find a p that turns out to be less than 0.05, when your p is less than 0.05, what is it implying? Interpretation is always that the difference that you are seeing is not due to chance, right? 你每次見到一個 p 細過 0.05， 你就話哦 OK， the difference is significant. It's not due to chance. 咁但係如果你真係做呢一個 test 喺呢啲 baseline parameters 嗰度，咁究竟個 difference 係 due to what? If it's not due to chance. OK， 其實呢個意思就即係話咧係唔 logical 嘅。It doesn't make sense. It's a wrong use of statistical tests if you don't understand it. Okay? And this is only makes sense, or it only makes sense when you suspect the randomization was not properly done. 即係你懷疑有人做數 ，OK， 有人使橫手做咗一啲嘢，令到呢兩個 group different。咁你可能做呢個 test 咧，就好似有少少仲講得通。但係正常嚟講，你唔會無啦啦懷疑自己個 randomization 有問題嘅喎，係咪啊 ？Okay, so that's the second reason. Basically, you cannot explain the result. That's what I'm saying, okay? Because if you have something significant, you're saying that it's not due to chance, and you cannot really say what is the problem. Did you fake the randomization? Okay. Finally, the last thing is, by definition of a p less than 0.05, you have a 1 in 20 chance that you will call a difference significant while in fact it was by chance. Okay, so for every 20 baseline characteristics test, one will show a significant imbalance with two-sided p-value less than 0.05 by chance alone. OK， 即係話當你呢個就係一個我哋叫做 multiple testing 嘅問題。當你用得呢啲 statistical test 太多嘅時候咧，呢啲 statistical test 本身嗰個flaw 啊，佢本身嗰個問題咧就會發咗出嚟㗎啦。你做一兩次，你仲可以話 1 in 20 it's a small chance。但係如果你做30次、40次咧 ，very likely you're going to fall into the trap of calling something significant while it's just by chance， 即係話你中咗嗰個3% 啦。Okay, so that's what we call the multiple testing error. And sometimes in some bigger studies, you do see more than 20 baseline characteristics that are being described, right? Meaning those statistical tests are being done like over 20 times. This would be the time that it's actually not reliable. The results cannot be believed in. Okay? 大家明唔明啊？呢個係我教咗咁多年咧，最要用腦嗰 part， 同埋最多同學係唔明㗎。你唔明絕對係正常㗎，你係可能要啲時間消化下㗎。係咯，因為我都成日同人拗嘅，其實呢一樣嘢。咁但係好多時都係又真係講唔通嘅。如果你明白咗嗰個道理，好多同學咧會做呢個 test， 即係一個 baseline characteristics， 佢去 run 下 statistics。我諗如果你係用一個prospective cohort design，meaning there's no randomization， 咁都仲 make sense 啲。因為咧係冇 randomization 㗎嘛，係咪？你唔係 randomize， 所以個 difference 唔係 due to chance 嘅。個 difference 可能真係因為有啲人洗咗還手，譬如話因為某一啲原因，所以先至俾咗 treatment 呢一個 patient， 因為佢可能係後生啲啊、健壯啲啊，就俾咗個 active drug 佢。OK， 喺嗰啲情況你去 test 都仲 make sense 啲。OK， 咁當然啦，其實test 咗之後咧，都係講唔到太多俾你聽，其實都係唔夠嘅。OK， so using the p-value to assess the baseline characteristics. Number one, if you were to do this with your observational studies, you also still need to think about the importance of the difference. Okay, it depends on the variable strength of association with your outcome, meaning how likely is this variable, like say the age. There is a difference between age in these two groups. Is this age going to affect your outcome? Is this magnitude of difference clinically significant? Okay, so the take-home point is don't just blindly run all these statistical tests. It's very unprofessional. Okay, it's not a substitute for really understanding your study. It's not a substitute for describing the imbalances and making the necessary adjustment. So there are many different statistical tests that are used to adjust those baseline factors that are known to strongly influence the outcomes. Okay, so just to name a few, the Cox proportional hazard model, it's very frequently used. A lot of people would use logistic regression. Whenever you see those studies that use logistic regression to see how the covariates are affecting the outcome. Sometimes after the LR, they might show and say, oh, the age was significantly affecting the outcome, or they might say all other factors are not significant. Okay, this is what it's being done, using the proper statistical test to investigate how these baseline characteristics or covariates have posted an effect on the outcome instead of the actual intervention. And then the next thing I do want to introduce to you, if you didn't learn before, is the propensity score. Propensity score is increasingly used, especially in observational studies. Now, in large randomized control trials, usually those baseline differences are not a huge issue because they tend to be fairly evenly distributed because your sample size is large. Okay? But in observational study, it's different. Now you choose your treatment.
to be given to a certain patient。大家知唔知道？好快啦，我問一問啦。其實大家仲記唔記得 cohort study 嘅 design 係點樣 ？case control study 嘅 design 係點啊 ？cohort study case control 記唔記得啊？呢個都要知㗎，一定。可唔可以先答 case control 先啊 ？case control study 嘅 design 係點㗎？點樣揾點樣去conduct 啊？應該話。喂，快啲啦喂！我仲諗住可以早幾分鐘俾大家放學㗎，冇理由個個都唔記得嘅。嗱，我自己記咧 ，case control 你因為個名係 case control，你揾咗個 case 同埋揾咗個 control 出嚟先嘅，即係揾咗咩出嚟先咧？就係揾咗有 outcome 嘅人同埋冇 outcome 嘅人，然之後你 go back to look for exposure， 睇下佢哋有冇某個 risk factor。OK， 呢個就 case control， 先揾咗有 outcome 同冇有 outcome 嘅兩班人出嚟，然之後 go back to track the exposure。cohort 咧就係 you start with the exposure or the risk factor, and then you follow these patients to see if they develop the disease. Okay? It could be retrospectively done or prospectively done. Retrospective 咧即係話喺你做個 project 嗰一刻咧，個 outcome 都已經發生咗㗎啦。OK， 即係個 study 嗰個 event 已經發生咗啦。OK， 所有嘢你可能抄翻5年前嘅 data， 跟住睇翻1年之後發生嘅嘢，有 outcome 冇 outcome。Prospective cohort 咧，即係話由今日而家你 plan 呢一個 prospective study， 然之後由依家呢一刻揾咗一 group 有 risk factor 冇 risk factor 或者話叫 exposure， 跟住你 follow to look for the outcome。OK， 其實 once 你記得 case control 咧，你好自然你就會記得 cohort 係咩啦，因為兩個係相反㗎嘛。Okay, so in those observational studies, treatments were often given to the patient in a real-life way, which is based on their own risk factors or baseline characteristics. Okay, and we know that all these baseline characteristics themselves can confound the treatment effects. Okay, so sicker, older patients, for example, when they have stroke, they might be given aspirin instead of TPA during a stroke. OK， 即係個病人病啲老啲，可能醫生就話咁唔好俾 TPA 佢啦，因為驚佢有危險，咁就俾 aspirin。咁但係當你去睇一個cohort study 嘅話，如果你咁樣去 compare aspirin 同埋 TPA 個 effect 係會好唔 fair 嘅，因為你個 aspirin group 可能本身就係老啲㗎啦，本身就係病啲容易出事嘅。咁你將嗰個 outcome 出事率掛咗落去個 aspirin 嗰度，其實係錯啊嘛，因為其實係因為佢係老啲病啲，令到佢可能出事率高啲嘅。Okay? And then if you look at this table I'm including here, you will have an even more clear picture about how, for example, gender itself can affect the outcome. So let's look at this, a non-randomized study with two groups of with a binary outcome. You know, this is just some hypothetical number. It's usually not as extreme, but still, you know, I think it gives a very clear picture. If you look at the overall first, 你先睇 overall. Group A 同 Group B 都有100人 ，OK。Group A 咧就有26個 out of 100個係 successful 嘅，咁係26% 嘅 response rate 啦。Group B 咧就係47%。如果你就咁睇，你會以為可能 Group B effective 一啲。But if you break down
to the number of patients who are male and female。OK， 咁你發現咧，原來咧喺 Group A 咧本身係多啲男人嘅。OK， 而男人嗰個 treatment outcome 原來本身係差過女人嘅。OK， 如果你淨係睇男人同男人嘅比較咧，你發現原來咧大家嗰個 success rate 咧都係20%， 1/5。睇翻女人同女人，大家嘅 success rate 咧都係50%。OK， 明白嘛？咁你睇呢個圖咧就好清晰啦，即係話咧原來有一 group 咧多咗男人，而男人本身咧就個 success rate 差啲個噃，所以影響咗個 outcome。So what propensity score does is it predicts the probability that an individual patient would receive the active treatments based on his or her own risk factors。OK， 即係話佢如果用頭先嘅 example， 佢係睇翻頭先一個老啲病啲嘅人有幾 likely 佢會被 allocate 去 TPA 個 group 咧。OK， so find individuals in both treatment groups。咁無論如何，老啲病啲嘅始終都會有幾個人係去咗 TPA group 噶嘛。雖然多數可能會係喺 aspirin group。OK， 你始終都會有人去咗 TPA group 噶嘛。OK，so they can find individuals in both groups for any propensity score and then check the balance. Or I can say they can find individuals in both treatment groups for a particular propensity score and then check the balance. OK， 緊啲最高 score 即係可能好老好病嘅，譬如係咁發現佢好多時會被人擺咗去某一個 treatment 嘅，咁然之後你 compare 個 treatment 同埋個 control， 究竟佢哋個 outcome 係點樣噶啦？So the score is calculated by certain statistical method. The good thing about it is it can factor in multiple observed covariates. If you remember, this principle is somewhat similar to the strata that we mentioned, right? Strata is trying to put your patients with the same prognostic factors equally in the two groups. This, you're kind of doing it in a different way because it's observational study, but again, you're trying to look at those risk factors and see how it has affected your allocation. So the score is calculated by some statistical method factoring in multiple covariates. Now it's more than just two prognostic factors. Okay, remember the strata you can only put in two, but this one you can put in multiple. So each patient has a propensity score depending on their own risk factor. 即係有人會高啲，有人會低啲 depending on their own risk. So the propensity scores are scores that are used to balance those prognostic variables across treated and untreated groups and use it to adjust for outcome. 最容易個理解咧就係用一個 matching， 即係第二個 point match the treated and untreated patients and compare those resulting match pairs。即係話，如果我哋話女性係一個 good prognostic factor， 男性係一個壞嘅 prognostic factor， 好似頭先嗰個 example 咁樣，咁你就係喺兩邊揾翻男性出嚟 ，OK？ 可能一邊 active 嗰邊可能係譬如少啲男性嘅 ，control 嗰邊多啲男性嘅，咁你咪淨係睇翻呢啲男性佢哋嗰個 outcome， 跟住你去話咦仲係有一個 difference 喎 ，active 同埋 control， 咁你咪知道active 可能係好啲嘅，就算淨係講緊男性 ，OK？ 咁你咪可以 balance out or match those risk factor 咯。OK， 咁而個重點就係 propensity scores 唔係淨係講緊一個 parameter， 佢係講緊男性啦、食煙啦、obese 啦、hypertension 啦等等，即係佢係將幾樣嘢夾埋集成為一個 score 咯。And this score can be applied in many other ways, like the logistic regression model. It can be used for weighing the outcomes as well. It's quite commonly done in the retrospective studies or some observational study where they couldn't randomize. So patients ending up being quite different between the two groups just because of their own risk factors or background. Okay. 有冇問題啊 so far?
大家自己嘅 study 可唔可以用 propensity score 呢樣嘢咧？其實要做起上嚟 statistical wise 係幾複雜嘅。咁你可唔可以做到？你唔係唔得嘅，不過咧真係要靠下我哋個 biostatistician 去幫你。咁所以咧，其實呢啲你都要諗一諗，就係我要 collect 啲咩 data 咧？如果我要計呢啲 propensity score，有冇啲咩特別我要準備嘅咧？喺你上 biostatistics 嗰堂咧，你就要問需要問嘅問題啦。OK， 好，有冇問題啊？大家？要啲時間消化下係嘛？嗱，咁暫時如果冇問題咧，咁我哋今日就到此為止啦。你可以咧儲住你啲問題，或者你諗過之後都係唔明咧，我哋下一堂即係下個星期六咧，我想下一個星期六我哋就 face to face 啦，因為你今日經歷過之後咧，我唔知你哋覺得點啊？咁我諗始終 face to face 個 interaction 都係好少少嘅，即係可能容易啲問問題啊咁樣，或者你會容易啲明白嘅，你會冇咁分心嘅。咁我哋不如下一堂就用翻 face to face， 等大家可以係咯明多少少，或者問多少少問題咯。好 ，OK， 冇問題，暫時頭都暈埋可能。咁好啦，咁如果係咁咧，我今日就 end 咗個 session， 然之後咧我就會將頭先講嗰啲 case assignment 啊、example 啊嗰啲，我會 upload 上去 Blackboard 嘅。咁大家可以，你可以早啲開始做㗎，如果你想嘅話，係咯。如果你有時間想 go ahead and get started， 其實你可以早少少開始諗下點樣做嘅。咁你就唔好將啲功課堆晒喺個 deadline 咯。係啦，咁當然同時間星期二嗰陣時嘗試揾翻起碼你啲 groupmate，咁大家開始揾下 journal article 啊咁樣。OK， 好，冇問題嘅話咧，咁今日到此為止啦。希望大家過一個愉快嘅星期日，我哋星期二晚會再見到你哋。拜拜。